different countries, and our hosts are Professor Joko Kato, Professor Ibrahim Omerhodžić, Professor Arsi Morina, Professor Mentor Petrella, Professor Ridvan Ali Mehmeti, and Professor Dr. Blerib Zachiri. I welcome all of you, and I will kindly ask Professor Kato to officially open this webinar.
Yes, thank you so much, Dr. Ali. So it is our great pleasure to welcome all of you. So this is the third time of the ACNS and also the Bosnia and the Herzegovina of the webinar. So this time is main theme focus on the spinal lesion. So of course, some of them are a bit different, the topics, but we will have 10 speakers. So all speakers, the title is very fantastic. So we should learn lots of things from all of the guest speakers. So shall we start? Or Ibrahim is here with us.
Yes, I see Ibrahim is here too. Hey, Ibrahim, welcome.
Hey, good morning, everybody.
Hi, how are you?
Good to see you again. Good morning,
yes,
Kato and all people here. Adi, yes, continuous, please.
Please. We have many speakers from many countries: Slovenia, Croatia, Germany, Bosnia and Herzegovina, Pakistan, Turkey, Japan, as well as United States of America. I will kindly ask each speaker to keep to the 20 minutes presentation, since I believe that we will have a discussion, and because the topics are very interesting. I welcome Professor Roman Bošnjak from Slovenia. Welcome, Professor Bošnjak. It's your hello. It's your time, so you can share your presentation. Thank you.
Just tell me if you see my screen.
Yes, we do.
Yes, and the voice is okay.
Perfect.
Oh, thank you. I would like to thank you to be invited in your company and to present this topic on endoscopic supracerebellar intratemporal approach to penile and posterior fourth ventricle lesions in such audience, such big audience. So this approach is good for tumors in children and adults, not only for penile cyst. And concerning this region, this is in fact penile protruding to posterior fourth ventricle or vice versa. The lesion that grow here most often, there are germ tumors and glial tumors, as you see here on the left, and the tumors from penile parenchyma itself. So we can see that this survival rate in penile tumors, true penile tumors, is very bad, especially in pineoblastoma. So here, strong surgery should be applied. We also see on the right side that there are some racial differences. So in Japan, glioma is not on the second place, but on the third. So these are some differences. These tumors are either benign and radiosensitive, or malignant, or radio-resistant, or disseminated. Because possibility of dissemination, whole spine MRI is always part of diagnostics, as well as taking the specific markers from CSF and from serum. If the tumor are benign and radiosensitive, there it's at least as an initial symptomatology comes with hydrocephalus. There is ATV as an initial procedure, which can be done the same time or separately with a biopsy or surgery. However, here we do not need to do such maximal radical surgery, but this is of course the situation in malignant tumors, because these are very resistant to any therapy. However, the third group, disseminated, they are not first surgical candidate. So this is for chemo and radiotherapy first. So here, how we approach to this deeply seated tumor, we can see on the left side that the trajectory to do ATV is not the same as for approach to the posterior fourth ventricle. So in this kind, we must go more front, more in the forehead. So in this way, we can approach till the aqueduct and remove the lesion behind the adhesio interthalamica. Here on the right is even more complex case using a rigid shaft and pushing through the flexible steerable fibroscope. So these both procedures, more or less, you can do a tissue biopsy or minor removal, more or less biopsy. However, I would like to present the endoscopic supracerebellar infratentorial approach, which can give us possibility to use microsurgery under endoscope control visualization all the time and do equally effective removal with that classical microsurgery. Because endoscope is a visual tool through the whole surgery. This is not endoscopic assisted, but we use endoscope for the whole surgery from beginning, from trepanation to the end. And here are some photos from Roton to show us this complex deep-seated area. Pineal is covered from behind with a bundle of veins, and these veins are, of course, critical. So there are many variations, and more the complex is this variation, more difficult is approach. Here is the view from above. You can see that we could approach fourth ventricle also from above through the body of the lateral ventricle by doing the transhoroidal approach. So we can nicely see the structures in the posterior part. This is entrance of the aqueduct, posterior commissure, then pineal, recessus, and habenula. The critical part, of course, is dissection of the severe arachnoid trabeculas, which are present around the veins. So this takes time, but we should take this time as maximal as possible and to do this without any harm to the veins. Classical microscopic approaches to posterior fourth ventricle is posterior transcallosal or posterior transcallosal, and classical microscopic to pineal gland lesion is occipital, transtentorial, or infratentorial supracerebellar. In our alternative, as you see here in the beginning, we were using the sitting position, but we are now using the, I will show later, anti-concord prone position. There are many possibilities except semi-sitting. It's also a park bench, like concord, like in these pictures below, semi-prone. But the position we found very useful is the position we called anti-concord. So the patient is set prone and the head is elevated, retroflexed, and turned to the surgeon who sits on the left shoulder of the patient. So there is some kind of surgery like reverse endonasal surgery. So we found this very useful because the venous drainage is enhanced, and also there is a gravity effect which would open the space between the tentorium and the surface of the cerebellum even much better. So this is some case series, and you see here we have 8 patients till now, and 4 of them are young children from 6 months to 15 years, but the others are older one. We published this recently 2 years ago, and in 8 cases we were using endoscopic SCIT, and in 1 case transhoroidal. So here we see that the lesion itself, which is expanding, it also expands the veins and makes our preparation easier. So this is the how we approach. We do a mini trepanation here under the torcula. So you can see here the under aspect of the tentorium and also the transversal sinus. And we first we were doing only from one side, from the right side, but later on we moved from paramedial to quite central approach. Of course, we must take care to not come too deep and to take care about the veins, because some bridging veins into tentorium, there are more posterior toward transversal sinus, and we work with the endoscope about 7-8 centimeter deeper. So we must find the right trajectory that we do not tear these veins. So here you can see the starting of the preparation of the veins, and we have a nice triangular space, and the vermal, superior vermal vein is the only vein that can be transected. But other veins must be preserved as well. And here, after dissection, we try to find the right entrance to our pineal region, and behind pineal region there is a posterior third of the ventricle. Here in this case, we are having the lesion, which is the pineal cyst, and you can see how it is firmly adherent, but it can be dissected bluntly from the surface of the tectum. This is what I already mentioned, and this is the preserving of the bridging veins. Here are some cases. The first one is a guy with a retinoblastoma, a young child, and this lesion was growing also, and we decided to do the surgery because it was a diagnosis of trilateral retinoblastoma, but luckily it was a colloid cyst of the pineal gland. So we use this approach also in small children. There is one important notice to say, and that is that after any surgery in this region, at the end, we should check the floor of the third ventricle. So mainly because this is the deepest part, there is certainly a hematoma which would produce closure of the aqueduct and hydrocephalus. So at the end, we always check this region. So here, what we see here on the left side, this is adhesio interthalamica. From this approach, we can't see aqueduct itself without angled optics. So here you can see how huge hematoma was moved after the end of the surgery. Because we do this patient had normal passage of the CSF, and he developed no hydrocephalus. So there is some other cases, a very rare case of pineal meningioma. It's only one I found in my praxis. And germinoma. Germinoma are very radio-resistant. And in this case, we took the CSF, and we were quite aware that this is the germinoma, so we did partial removal, but I would say maximally safe removal. So there are only a tiny layer of tissue on the walls of the thalami here. Here you can see the germinoma is quite a solid tumor, but it is aspirable. So when we enter the third ventricle, we see adhesio interthalamica checked for hematoma, but here on the side, there is a tiny layer of tissue. So this is the case of the arachnoid cyst. And after broad fenestration, we see that the cyst has relaxed. This is a sad case of diffuse midline glioma. This is a very bad prognosis. So we did a fine surgery here in this 9-year-old girl. But after 5 months, the operative area was clear of tumor, but there are 2 seedings, one more anterior and the second dissemination here at the vestigium. So she died in the 6th month. So this case is also interesting because CSF showed us this is the probably one of these tumors which are which have markers. So we started here with chemotherapy first in this young boy, and the tumor really shrinked, but not as much as we expected. So after 3 months, it was still from 24 to 15 millimeters. But later on, we decided for surgery because this guy had no chances of long-term survival without maximal safe removal of the lesion. Here we see the yolk sac tumor was here dissected under endoscopic vision sharply. So we can see that this is the vision which probably microscope can't give us, because we were seeing the plane immediately after observance of the endoscope very close. So at the end, we have this nice both putamen, thalami. We see these medial choroidal arteries and gross total removal of the tumor. So this is the case with the control MRI showing no tumor, and this guy is doing very fine, and it is now 4.5 years after surgery. So this is one case of our nurse in our department. All 30 years she was with me. When I come to the department, she was the nurse, and then she got some psychic problems just before retirement, and there was a lesion in the tectum. And we did, with this approach, a biopsy only, and it revealed diffuse astrocytoma of the tectum of the mesencephalony. And this, of course, due to any treatment, this progressed, and there was only 16-month survival. At the end, I would like to present one alternative to this approach. So in case that tumor is predominantly in the posterior fourth ventricle, like in this case, we should use probably a supero-anterior approach through the choroidal fissure. This main is that we dissect plexus choroideus away from the fornix, and in this split, we can then come to the tela, and between the two great cerebellar vein, we can enter the fourth ventricle in direction toward the aqueduct. So in this case, this is the settlement. We removed the lesion here completely, so it's nothing in front of the aqueduct. And the surgery revealed papillary tumor of the pineal region, and the patient was then radiated, and he is intact after 2 years after surgery. So we were doing this endoscopic procedure through the tube. So this was transtubular endoport surgery, and we made tube in this way. So we use PVC wrapping like this, and we remove the shaft which is holding this, and we stereotactically insert into the ventricle. This we expand with Fogarty catheter, and this is our view. And after this expansion, we put 3 instruments in this endoport, which is about 11 to 15, sometimes millimeters large. So we are working with the endoscope, which is held by assistant, and the surgeon works with 2 hands, with 2 instruments. So he's performing microsurgery. So here is a nice view to the aqueduct. I think this is the only approach to show aqueduct so nicely with 0 optics. And thereafter, we remove our cotton between the both internal cerebral vein, and the tumor was removed completely, as I showed before. And here is the last case of this 10-year girl, and he had this lesion, which was partially in the posterior fourth ventricle, partially in pineal, and going through aqueduct to the fourth ventricle. So we decided to have 2-stage surgery because this was a complicated girl and her mother, and they refused initial surgery because this was a hydrocephalus in the beginning. ATV was done, and she was fine. So after 2.5 years, like you see above, this tumor has been growing, and it had this enormous size. You can see here on the right side, it practically doubled. So we decided to remove first this part, the majority in the posterior fourth ventricle, and secondly, we do removal through the endoscopic supracerebellar, and this part in the ventricle to the endoscopic talovelar. However, after this second surgery, when this tumor was nicely removed where we expected, of course, it's not removed here totally, but the patient again refused further surgery. So we are waiting now for recidivant. So sometimes our patients are not helpful. To conclude, I would say that endoscopic supracerebellar infratentorial tumor offers us direct approach to difficult deep-seated regions. The gravity helps to expand the corridor. We work in the midline. We use microsurgery and the anatomy until the lesion is predictable. It's deep, but these veins and surrounding eloquent structures are predictable. Also, endoscope offers us a panoramic view. We can equally work left, right, up, down, and we can also use angled optic. Of course, we must have a dedicated instruments to perform all these tasks, because microsurgery with endoscopic control is a bit different because of the minor space we have through the area or through the tube. But I think this is at least equally effective as classical microsurgical dissection. Thank you.
Thank you for outstanding lecture, Professor Bosniak. Great cases. I will kindly ask, do we have any questions from the audience about the lecture?
So can I? So just the Professor Roman, thank you very much for excellent, the beautiful video and also your concept. So I think very limited working place with the endoscope. So of course you said the high illumination, resolution, and magnification, and the 360-degree panoramic. But I think what is you do not recommend as an indication, and also what is the most difficult situation? Just let us know, please.
Yes, I would recommend this only for smaller midline tumors. This is the point. So it is not suitable if there is extension or infiltration in the thalamus or in the cisterns or even in another fossa. So it's only for midline centrally positioned smaller tumors, about 2.5 up to 3 centimeters. I think this is limitation. It's a safe limitation, I think so.
Okay. So do you have such kind of the huge bleeding during surgery? Do you encounter such a situation?
Of course, there were injury, but if you work careless and slowly, these injuries are not big, but generally they come from tearing because of pulling, because dissection is under control, scissors, but pulling is not under control. But in this way, I tried to close with Tahosil. So I push this small patch of Tahosil and wait that it adheres, and then I try to continue.
Excellent. Thank you very much. Congratulations. Wonderful talk.
Thank you. Do we have other questions, please, from the audience? Professor Bosniak, as I noted, you use a rigid scope, right?
Yes.
Do you believe that the flexible scope would improve possibilities of endoscopic resection of pineal region tumors? Do you believe that you could achieve more in larger lesions than you showed in your presentation?
Yes. In the future, maybe yes, because flexible is only a tool for visualization. But I think that the problem will be in instruments to work around in corner. That's the thing.
Okay,
There will
thank you.
be some, yes. But I have no experience with flexible yet.
Okay, thank you. Other questions, please? Okay, so if there are no questions, we could proceed. Next should be Professor Rotim from Croatia. Professor Rotim, are you here? I don't actually see any panelists that we have.
Hello. Hi, Adi. It's Domagoj Gajski. Unfortunately,
Hey, Domagoj, how are you?
Unfortunately, Professor Rotim wasn't available to give a lecture now, so he kindly asked me to step instead of him, and I will give a lecture today for you. Okay?
Okay, thank you, please.
Just a second to share the screen. Okay, do you see the screen?
We do. We hear you well.
Okay, great. Then I can start just to remove this from site. Okay. So today I will talk about intradural spinal tumors, our surgical consideration, institutional experience. We are coming from University Hospital Center, Sestre Milosrdnice in Zagreb, Croatia. Zagreb is capital of Croatia, and we are the second largest hospital in Croatia. This is our main building of the entrance of the hospital. And so when we talk about intradural extramedullary tumors, we mostly talk about schwannoma, meningioma, and neurofibroma. But when we talk about intramedullary tumors, these are astrocytomas and ependymoma mostly. You can see them here on the picture in the thoracico-lumbar region. What was the goal of our study? It was to evaluate the effect of surgical treatment on the symptoms and the quality of the life. So we wanted to see how we wanted to expect to see what we can expect from the surgery when we have some older patients maybe, and we were observing the situation with the size of the tumors and location of the tumors due to the treatment. So this is a study from 2010 to 2019. We excluded from the study craniocervical junction tumors, and we included 3 extradural tumors which infiltrated spinal dura. So what we were observing, preoperative pain evaluation. So we did analyze our patients with visual analog scale, which is from 1 to 10. That was the way how much in pain they were. And we were looking at the neurological deficits. So we had 5 categories. We had the category no deficit at all, sensory deficit, motoric deficit, sensomotor deficit, and sphincter deficit. Surgical procedure, it was done from positioning. We used X-ray on the beginning of the surgery, of course, to mark the level where we are. In almost all patients, we used evoked potentials, which we like to use when we are having this kind of operations, and mostly performed were laminectomies, laminotomies, and hemilaminectomies. So case number 1 is a female patient, 74 years old. Preoperatively, she didn't have pain at all, but she had a sensomotor deficit and sphincter deficit. What is important here is that the age did not seem to contraindicate surgery. And we will see later how good results she had. So this was the tumor. As you can see, this is the thoracic, the beginning of the thoracic spine. It was positioned intramedullary. This is a video from the surgery. So this is an incision dorsomedially of the dura, opening it. You can see the tumor. Sorry, you can see the tumor here within the spinal structures, the nerve structures. And this was the resection of the tumor. We always cut the ligament dentatum to make it more flexible for the medullar spine. I will make it a little bit faster. It was a quite big tumor, but you can see it had a quite good border to the other anatomical structures. And we have successfully taken it out. A lot of irrigation is always necessary. And this was the closure where we put always Stachocele almost on the watertight sutures, which we put before, and then we put above the fibrin glue. This is the post-operative MRI. As you can see, the spinal canal looks well. There is no residual tumor tissue. So the pathological examination showed us that it was meningioma, and what is important, at 6-month follow-up, there was of course still no pain. The urinary sphincter was recovered, and she had only some little sensory deficit. Case number 2, it was again female, but 54 years old. She had preoperative pain on the VAS scale number 5. She had reduced left arm motor strength 4 to 5, so it's 20% lower, and she had a C6 paresthesias. We can see on the MRI scan one intramedullary position tumor on the level of C4, C5, mostly C5 cervical spine. And we have performed surgery. Again, we have performed the laminectomy of the dorsal part of the spinal of the arcus, laminectomy, and we have done the dorsal medial incision. We positioned the evoked potentials for the delta wave here. It always goes cranially. And we have, as you can see here, opened the fissura dorsomedialis and going for the tumor, which you can start seeing now. It is a soft tumor. You see how it's quite easily get dissected. And removed in one piece. Now, a lot of irrigation, checking with the evoked potentials for any new sensomotor deficits. Watertight sutures. And here we perform the laminotomy. So as you can see, we placed back the laminas. This is the patient post-operatively on our department. And you can see here, there is no residual tumor issue. So pathohistological examination showed us that this was the ependymoma, WHO grade is 2. At the 6-month follow-up, as you remember, there was a VAS level 5, now it's 0. There were some left arm paresthesias, but with normal motor strength. So altogether, when we talk about these patients and our experience, we had a distribution 50-50 between male and female. The mostly positioned tumors were thoracic tumors, and then the lumbar region tumors, as you can see on this slide. Position of the tumor and the age of the patient was, let's say, connected with causes. You can see in the lumbar sacral region, we had mostly the older patients, while the younger patients were cervical and thoracic spine, thoracolumbar spine, and lumbosacral sacral for older patients, as you can see in this graph. When we talk about the histology, so in cervical spine, mostly we had schwannomas. Thoracic region was mostly with meningioma tumors, and lumbar region was with schwannoma. And as you can see, when we look all spine together, the most meningioma was altogether thoracic spine, and we didn't have meningioma in cervical and thoracolumbar spine. And when schwannomas, we had the largest number of patients in the lumbar spine, but they were occurring in every spine region. Epidemomas, we had only in cervical and thoracic, of course, spine. When we talk about the histology, so in thoracic spine, in our study, we had some gliosarcoma, we had some rosy deformant disease, hemangioblastomas, teratomas, so there were quite a lot, and interesting other cases which are quite rare, also described in the literature. Histology and the age of the people. So as usually when we have meningiomas, they are mostly occurring in the elderly population, and we had median age of 63 for these tumors, while the astrocytomas and epidemomas were at a much younger group of patients, almost 20 years younger when we're looking at the median age. So results altogether, our oldest operated patient was 85, the youngest was 70 years. Both were males with schwannoma diagnosed. So here you can easily see how schwannoma is definitely one tumor which is occurring in almost every time of your life, and not only when you're younger and older, like it's maybe with meningiomas. Hospital stay was between 4 and 22 days, average 80 days. We had 3 complications. It was 2 licorias and 1 pneumonia. Also, we had 1 patient who died within 1 month after surgery. It was a patient with gliosarcoma. It was 35-year-old male. And after surgery, he was after our surgery and resection, this gliosarcoma was quite good. But within a couple of days, we have performed a control MRI scan, and we could see the spreading of the tumor on the brain, on the lower levels of the spine, and unfortunately, he died within a month. We didn't fuse any of our patients, and to get to not today, when there's a lot of years passed after the last one and first, of course, definitely there was no need for fusion for any patient. Median age, as I have mentioned, of the meningioma was the highest, and the location mostly thoracic spine, and the epidemoma and the astrocytoma were mostly in the younger populations. Also, we had a good result with a patient with sphincter dysfunction. They had a full recovery. There was 5% of the patients with it. Also, our patients with preoperative motor deficit had it after surgery 40%. Recovery of the preoperative sensory was much wider and better. It was 50%. And this is all I have said. What I can say mostly that the median age of schwannoma was between meningiomas and epidemomas. If you remember, meningiomas were around 60s, epidemoma 40s, and schwannoma 50s years. So in the conclusion, what you need to learn is that advanced age is not a contraindication for the surgery. As you know, the surgeries and the technology and the anesthesia is going much better. The population is also getting older, and this is very important because a lot of people think that when someone is 80 years old that he shouldn't be operated or something like that, but it's not true. You need to give to absolutely every person a chance to recover. The only contraindication here is the contraindication when anesthesiologists say. When we talk about the neurosurgery, there is no contraindication. So the worst results we had on the patients with motor deficit, because they had only 14% recovery. When we compare it to the sensory, which was 50, it was really bad, let's say. Sphincter dysfunction, this was best, it was 100% recovery. Also, what you need to think about when you have a patient in your ambulance, when you talk for it for the first time and you're looking at the MRI, which is maybe of the lumbar region because of some sensory deficit in the legs or some pain in the back, you need to think that the older population mostly, if you don't find anything on the lumbar spine MRI, you should do it a thoracic spine MRI and check it for maybe potential some meningioma or tumor or some similar tumor in the spine channel. Also, in the younger population, always think about the lumbar and cervical spine. So when you have patients with problems with leg, don't forget that it can come from the cervical spine as well, and check it if it's necessary. The location affected the post-operative neurological deficit, and the worst results were for cervical and thoracic tumors, unfortunately, due to the medulla spinalis, which is there, and as we know, in lumbar spine, it's cauda equina. In the end, I would like to invite you for the symposium. We are at a Congress. We have the 5th Sense Congress next week, which will be held in Opatia, and you are all welcome here. I know that some of you will be here who I see as the panelists, and the others I invite to join us and enjoy integrate lectures. Thank you very much, and greetings from Croatia.
Thank you, Domagoj. Great lecture, very great results, good series. I like your technique and how you did it. Do we have all questions, please? Ibrahim, maybe from...
Thank you, Domagoj. Thank you, Adi.
Good morning. Hi.
Hey, morning. Nice lecture, of course, nice video. I would like to ask you just one question concerning the neuromonitoring. As you mentioned that you usually using the neuromonitoring for those kind of surgeries. Do you think is there really a benefit from that? And if yes, what do you think? It's obligatory, or is just obligatory for intramedullary tumor or intradural, or the same? And just to give us some experience, your experience.
Okay, so we did we did a neuromonitoring in maybe 99%. It was only one patient where we didn't do it, and it was because our doctor neurologist who is doing it was sick at that moment, and we need to perform the surgery. It was on the lumbar spine. I think it should be obligatory. From my own experience, there were a couple of situations where we were performing surgery. It was sometimes intramedullary, sometimes was extramedullary tumor. But what is the thing? The thing is that she is taking, as you know, what is neuromonitoring doing. So you're checking the signals of their spines. And in one moment, we had one large tumor, and while we were dissecting it, for example, we as a neurosurgeon you don't see every part of the tumor, because you start your dissection, for example, from the cranial part. And as we were removing the other structures, in one moment, we lost some potentials to the nerves lower. So in that moment, our neurologist said, stop. And immediately we stopped with our dissection, we stopped with our surgery, we do a lot of irrigation with warm water, with warm physiological, and we are waiting for the recovery of the potential of the nerve. And during that time, then when we have the recovery on her screen, then we continue the dissection. So I think it's important, because if, for example, in that moment we didn't have this information, we would continue and maybe we would do some damage, because dissection doesn't last 10 seconds, sometimes in less, maybe 1 minute, 10 minutes, 15 minutes. And if we are maybe pushing the nerve structure for that longer time, and we are not aware of the damage we are doing in that second, that moment, we can do maybe some irreversible damage. So I think that the neuro-evoked potentials are definitely important, that we definitely need them. And if we want to be honest, for us neurosurgeon, it's no job at all. I mean, we all what have to do is to put the delta wave wire inside during the surgery, and everything else is done preoperatively and monitored by other doctor during the operation. So I think that we should have it, and that it definitely gives the quality of the surgery, and it can help our patient to be better in the end. Thank you.
Thank you, Domagoj.
Thank you, Domagoj. Do you have your neurologist who is just expert in neuromonitoring in the OR, or it's just ordinary neurologist?
No, we have one neurologist. She's a full-time working on neurosurgery, yep. And we use her for these evoked potentials in the OR operating room when we need it, and she's also doing for our patients which are hospitalized, administered to the hospital, EMGs or some other neurological examinations or tests we want to perform. And she's only working on neurosurgery department. She's not connected to the neurology department at all.
Okay. Next question is, do you sometimes in spinal tumors, in intradural lesions, do you do unilateral laminotomy or laminectomy unilaterally? Or you always go for?
We have performed sometimes for intramedullary tumors. We always perform the laminectomy because the position of approach is dorsomedial fissure, and it's, let's say, important. I mean, you can enter it maybe when you do hemilectomy, but it will be much harder. So we always do the laminectomy or laminotomy. Hemilectomy or unilateral laminectomy, we are performing sometime for the schwannomas, which are, let's say, positioned definitely on the one side of the canal, or maybe even when they are closer to the foramen and the nerve, even extradurally.
Great. And third question is about the CSF fistula. How did you solve it in those two cases which you showed? What is your strategy in that case?
Well, when it's the CSF fistula, you mean because of the collection, which was dorsally? Well, we didn't do anything. So we were waiting and giving time for the patient, and all patients were fine. We didn't have any infections, and we didn't have any CSF leakage on the skin. So we didn't do anything for the surgery. For this CSF leak, we had in a couple of patients. When we have it, we always perform the reoperation where we open again, check again our sutures on the dura and see if there is any leaking, and put another suture. And in the reoperation, we sometimes put even more of the fat tissue.
You mentioned that you haven't performed fusion.
Sorry, I didn't hear you.
I don't know, something has happened. You haven't performed any fusion. What is your opinion and experience? When should patient be fused after laminectomy in a spinal tumor? Which location? What is the criteria for it?
Well, mostly the book says that it should be done, if I'm quite well, when we have 3 or more laminectomies. We had one patient where we have done 3 laminectomies, and we were observing, we have done some scans, and we didn't decide to do the fusion, and the patient was well. Unfortunately, we had some patients, but after this study, it was in 2021, and we had one couple of months ago where we had to perform, it was ependymoma. It was, I think, 5 or 6 thoracic levels. So in this case, we have done fusion immediately, because 5-6 laminectomies without fusion, I think it would be a disaster. But when you have it like 2 or 3 levels, I think you can observe individually the patient and decide. For example, if your patient is 3-level laminectomy for the tumor and he has a problem with obesity or something like that, you need to expect in the future that his weight and all will probably do some spine deformity in the problem, and then you can immediately fuse it. But if you have a thin young patient with a good muscle strength and you do a free level laminectomy, maybe even you, let's say, do mostly minimally this laminectomy as much as you can do it, I think the fusion would not be necessary, and definitely our experience showed that it's not necessary.
Okay. Thank you, Domagoj. Great lecture. Thank you so much. You shared your experience with us. Next speaker is Dr. Dragan Jankovic from. Sorry.
Please, I think so. I have the message from Dragan. He has the problem with the connection just now. So I would like to invite the Mirza, Professor Dr. Pojskic, if he's ready, just to change the schedule for one lecture.
Yeah, Dragan will join us later.
Yes,
so
Dr. Pojskic is here. Dr. Pojskic.
I see Mirza in panelist, so
yeah.
I believe he is here.
Adi, I need 2 minutes. I'm right away here.
Okay. We can wait for.
Is there any discussion from other professors from the audience? Professor Bosniak, I hear Professor Brkic, which is here also. Professor Kato.
Well, thank you very much for a nice presentation. So just I want to ask, maybe I'm not a spinal neurosurgeon, but I think in the future, so do you have any idea to minimize or minimally invasive so treatment such as the pathology? Do you have any idea, or just let us know, please?
Well, to be honest, we were not even thinking about that, the minimal invasive taking out those tumors. Do I have an idea? I mean, it would be quite challenging. I mean, for some smaller tumors, maybe ependymomas or something like that, you can do it. But for some larger meningiomas and so on, I think a minimal invasive approach would be quite challenging, because removing such a large tumors from this channel, and while you need to perform some bone opening and laminectomy or something like that, I think I really don't know how it can be done. Okay. I'm not sure. Probably the technology or something like that will make some clear way, but now at the moment, really, I have no idea.
Okay, thanks. Great.
So Mirza is here. Welcome, Mirza. I believe that maybe he can share, since his topic is robotics in spine surgery. So let's see what the robot can do instead of neurosurgeon. I'm joking, of course. Mirza, if you are ready, you can start your lecture.
Ready. So thank you, first of all, for the kind invitation. It is my honor and pleasure to participate at this webinar with many of my teachers from Sarajevo and from Zenica, where my career started. I will just introduce myself shortly. My name is Mirza Pojskic. I'm a neurosurgeon at Department of Neurosurgery, University Hospital Marburg. For the flyer for this webinar, I was introduced as professor. I'm currently in the process of obtaining a professor degree, but I'm not a professor of neurosurgery yet, and I just wanted to disclose that on the beginning of this session. This is where I work. This is University Hospital Marburg in Germany. Our chairman is Professor Nimsky. He is a very famous name when it comes to medical technologies and when it comes to intraoperative MRI. The first intraoperative MRI in Europe was introduced back then in Erlangen, where he used to work. And one of the major landmark papers on intraoperative navigation and the brain shift comes from his research group. So we have, as a department, a large tradition in innovative medical technologies. So robots are everywhere, and it was the 80s and 90s when they started to come to our homes, first as toys for kids, and then later in all possible places in our life. And my talk was actually robotics in spine surgery, but I'm going to give a brief description of use of robotics in neurosurgery in the whole neurosurgery, because we have in this webinar many neurosurgeons who are more in the cranial business. So I would just like to give a short scope on everything what robots can do today. So between imagination and reality, I think this slide depicts it good, because our imagination, what we think and what we thought 20, 30 years ago, what robots are going to do, what they actually do, there is a big discrepancy, and I would say also disappointment. But as in many technologies, sometimes it is necessary to wait 50 or 100 years before a certain technology makes a giant leap. And I think that we are standing at this moment right in front of it. So by the definition, a robot is any reprogrammable power manipulator with artificial sensing that can assist in a variety of surgical tasks. And the first application was in the 1980s. There was a robot called Puma 200. And delicate neurovascular structures and narrow corridors limit the expansion of robotic surgery. So this is Puma. This is how it looked in the 1980s. But when you look at the robots which we use today in the spine surgery, they are not many different. They look nicer, but they are not, the design is a bit more modern. But what they do and what they can do is at the current moment not very different from it. So this is one scope or one short presentation of the neurosurgical robots which are in use today. And when it comes to classification, there are several classifications on position control, role-based, function, technology, on technique, and on interaction. But probably passive robots only serve as a tool-holding device once directed to desired position. Semi-active devices perform the operation under direct human control, and active devices are under computer control and automatically perform certain interventions, for example, bone machining. Systems that are able to perform fully automated procedures, for example, CT-based biopsies, are called autonomous or supervisory controlled. And if the robot is entirely remote controlled and the surgeon is in charge of every single motion of the robot, we may call it a teleoperated system. So this would be an example of supervisory controlled robotic system, of robotic telesurgical system, where surgeon controls the robot in real time through the haptic interface, and the shared control systems, which are the most common robots, where robot and surgeon remain jointly in control. The surgeon remains in control of procedure, while the robot provides steady hand manipulation of the instrument, and this is what we use for pedicle screw implantations. So application of robotics in neurosurgery is mostly in spine and for stereotactic biopsies, and further applications are being investigated in neurosurgical technological laboratories and in cadaver laboratories. Why do we need them? Well, we have a history of neurosurgical innovation, especially in stereotaxy. The tight anatomical confines that are armored and oriented very specifically to bone structures, which makes the navigation easier. Microsurgical nature of our procedure, technical nature of our field, growth, the need for growth in minimally invasive neurosurgery, and a culture that adopts and embraces new technology with optimism. So when we talk about robots, we actually talk about cobots. Cobot surgery means that robot assists with the distinct but critical and sometimes difficult task of the operation. Step of anatomical localization, stabilization of the surgeon's hands during prolonged microsurgical work, or targeting of a pedicle screw. In the future, it may be necessary for not just one, but several robots to assist in completing a routine neurosurgical procedure, and I'm going to show a recent paper where that is already happening in neurosurgery. So for design, important are mechanical factors. We distinguish between rigid tools, which are most common in spine and endoscopic surgery, and curved tools for transnasal approaches, biopsies, endoscopic craniotomies to minimize invasiveness and reduce recovery time. And it is important to find a balance between size and strength and the stress of the tool is under. Improvement of human-robot interactions, the most important is the haptic feedback, so that the surgeon has fingertip feeling of what the robot is doing and where the robot at the current moment is, like with any surgical instrument. Force sensing with strain gauges and optical force measurements, proprioception feedback, transfer of our proprioception to the robotic arm and vice versa, kinematics for motion amplification and filtering, visualization, integration of all visualization, including endoscopy into the workflow, in training with programmed virtual reality and preoperative preparation virtual reality used to rehearse for the surgery. So in stereotactic neurosurgery, robotics are state of the art now. These are some recent papers which show the many applications of robotics for stereotactic surgery. This is, for example, from the recent open access publication for the use of MedTech ROSA 1 robotic robot for robot surgeries and for laser interstitial thermotherapy and stereotactic biopsies. In epilepsy surgery, recently we have an MRI-guided laser interstitial thermotherapy, also assisted by a robot. Everyone who is interested in robotic surgery and wants to know more, there are loads of open access papers nowadays, for example, like this, which I sincerely recommend everyone to read. And the literature shows that for functional neurosurgery, stereotactic neurosurgery, deep brain stimulation, and epilepsy surgery, we have a reduction of operative time, we have a reduction of human error, and increase of correct electrode placement. And this recent publication, just last month, targeting the future developing and training curriculum for robotic-assisted neurosurgery, we have now departments which developed a curriculum to become a structured tool for assessment of robotic education neurosurgical training. And what is now only access, which is a publication worth, will be probably in departments which have a lot of these cases in 5 to 10 years standard. In cerebrovascular neurosurgery, there are several robots which are approved for cardiovascular and peripheral vascular interventions like Corpat, GRX, Corindus, Niobe, Magellan, and Sensei. And advantages are precise device control, elimination of tremor and radiation exposure reduction for coilings. Disadvantages are cost, duration of training, and loss of tactile feedback, which is critical for performing fine motor tasks, but this is disadvantage of robots in general. So for robotics in spine surgery, current use is only for assisted pedicle screw placement, i.e. placement of K-wires. Why is it important? Well, screw placement can occur up to 8.7% of the time and can lead to clinically relevant symptoms 0.2 to 21%. First robot for spine surgeries was Mazor for spine assist or Renaissance from Israel in 2004. Now we have almost more than 10 different robotic systems from entire the world. And you have every year 3 or 4 new robots. I'm going to talk about it a bit later. At my department, we use Circ from BrainLab, and I will also show a short video which depicts how does a robot work. So what are the pros of robotics? You have a reduction of operative time, but this would be reduction of time which you need to implant screws. Actually, the surgery time is longer because installation of the robot and all technical issues which come with that actually prolong the surgeries compared to classical approach. Reduction of wound surface and wound healing deficits, high pedicle screw placement accuracy. When you compare it to freehand or to navigation, it has a 99.5% navigation accuracy. You have a decrease in revision and complication rates. This is applicable with O-arm and ICT. So cons are, like I said, registration and installation issues due to that longer operative time. And the learning curve so far has mostly shown no improvement of surgical efficiency, although we have a recent paper, which I'm about to show, which shows that there is actually a learning curve. But that learning curve is not dependent on the experience of the surgeon. And that is also a new moment when you have a technology where surgeon who is a resident and surgeon who is a senior surgeon do the surgery with exact precision, exact speed, and exact quality for the patient. Well, in this recent evaluation from Minds of robotic guided minimally invasive implantation, 2,067 pedicle screws. They had 413 surgery, 9 misplaced screws in 7 patients, and screw accuracy of 96.7%. And when you compare the robots to freehand, you have 5.8 times lower risk for a surgical complication and 11 times lower risk for revision surgery with similar surgical time. And this single surgeon study, which comes from Mao and colleagues, they showed that when you compare O-arm navigation versus Mazor X, there was no difference in the rate of clinically acceptable screw, of infection rate, and of intraoperative blood loss. Now, for spine robots, we have passive and active robots. Active robots would mean that the robotic head on itself aligns automatically to the pre-planned screw trajectory. And passive robot is the one which you as a surgeon need to bring to that trajectory and align it by yourself. So we've published an initial experience with our robot, with Circ, in December last year. And we have implanted around 200 screws so far with that. But as you see in Japan, Professor Ebara recently published that he has implanted 2,000 screws with the same robot. So he's obviously a spine surgeon and has a possibility to use it every day. We have a possibility to use it once a day in our CT suite. And there are now research groups all over the world which use Circ on a daily basis. This would be our operative setting. On the left side, you see the head of the robot with the active trajectory. And on the right side is our operative setting with intraoperative CT, with navigation camera, surgeon positioned on the left from the patient where the robotic arm is, the OR nurse. So what are the steps when you want to put robotic screws in a person? You have to do preoperative imaging, screw planning, then intraoperative imaging with automatic registration. You have to fuse the preoperative and intraoperative imaging, review the pre-planned screw trajectories, and then do the robotic-assisted insertion of key wires, followed by fluoroscopy-assisted insertion of pedicle screws and the control ICT scan. So this was a patient who had a metastasis of brain cancer, was to get this long construct. We planned the screws, and then we did the scan intraoperatively, fuse the two scans, revise the screws, and then the robotic arm actually guides you to the entry point and provides a perfect robotic holder, arm holder, and all you need to do is then to use a drill guide over that holder. This is how it looks in the OR, and I will try to show this video. I will just fast forward it. So these are skin fiducial for registration accuracy check. We put the reference array via a separate skin incision, proximally usually from the place where we want to operate. We do the intraoperative CT scan, excuse me. And so the surgeon puts a robotic arm over the pre-planned entry point. And sorry, I don't know why is this. So the robotic arm does this by itself. It aligns by itself to the trajectory of the screw. And I have a holder. Through this holder, I go with a trocar on the spine, do a small skin incision, put this navigated instrument directly on the entry point. And through this instrument, I'm then capable of doing drilling like here. And then I have a perfect trajectory in the pedicle, and I put the K-wire over this trajectory, and then over that, when I remove the robotic head, we put the pedicle screw. So robotic assistant allows for placement of screw with great screw diameter and length compared with surgical navigation alone, although with similar accuracy. It has been used even for cervical pedicle screws. Here, a case series, 12 patients. They had 14 screws with medial breaches, but less than 1 millimeter and with no clinical consequence. And this is the recent meta-analysis on 64 studies and over 20,000 patients, which showed less risk of inaccurate placement regardless of control arm approach, fewer reoperations, complications, lower blood loss, but increased operative time. And for the learning curve, these researchers from Korea also showed the most time-consuming fraction ROSA usage component was operating theater preparation and device installation, but they had a learning curve of 90% with the largest slope occurring around 20th surgery. And this is what I was talking before, that you have two robots. This is from Jerusalem, the recent paper. You have one robotic flat panel 3DC arm, which does the scanning, and it is connected to the robotic guidance platform Renaissance from Azure. So robots are currently unable to decompress, decorticate, or contour or place rods. But This recent paper from USA, from famous group of Mohammed Albar, showed that excessive Cambine's triangle intracutaneous transpyramidal interbody fusion is also possible with robots, iliac fixation, metastatic cancer, and sacroiliac fusions. So on the left side, we see the 4 new robots: T-Robot from China, Kulik Spine from Korea, Essential Cobot, and Excelsus, which hit the market last year. And on the right side, a press release from Dr. Goldstein from NYU, who is using now Excelsus from Globus, and he showed that he can do quickly long deformity surgeries. And I think that's the biggest application of it, when you have to put 20 screw in a person, that you can do it with this with the robot very quickly, very safe and accurate. So what is the future? Now we have a problem of restriction of working hours, so then you have less trained spine surgeons who are expected to do more and more. And currently, spine robots simply act as guides to help position tools in ideal position or trajectory. And the biggest future is that I think that at one point, the legislation is also going to say, if you have a possibility to use something which can make the perfect accurate placement of pedicle screws, then you will be obliged to use it. The future is bright. We have development of robotic suit in the OR, which is already happening. What our future directions are also safer and more thorough decompression, navigated and automated osteotomies for deformity, incorporation of artificial intelligence, MRI-based navigation, which could enable soft tissue handling, including disc work and tumor resections and cage implantations. We have now laboratory work, which does the spinal tumor resections, radio frequency ablation, and osteotomies in deformity surgeries. And as with any technology, when a lot of people start to produce these things and a lot of people start to use it, then it is going to be, the cost is going to be lower. And incorporation of Internet of Skills and artificial intelligence with 5G network is going to enable that you perform surgeries on a distance of several thousand kilometers, which is already happening in China. Future ideas are use of robots that are passive but provide no-fly zones around protected structures, such as the Dura robotic laminectomy, gloves with motion sensor, which follow follower robots, similar to the so-called intuitive robot, and automatization of simple procedures, such as wound closure. So when you compare robotics with augmented reality, which is also a high-end technique, you have also a superiority of robot-assisted instrumentation with less risk of inaccurate screw placement, fewer reoperations, fewer perioperative complications, and of course, as always, increased operative time. For robotic-guided skull-based surgery, you have use in the daily practice, which is minimal, and it is mostly connected to endoscopic endonasal approach. And here is the main thing to reduce the size of robot-assisted systems, such as the surgical Da Vinci surgical system. You have this publication, which is also open access, which shows that a review on a skull-based neurosurgery, and it is mostly around robotic holders who are used for transoral or transnasal endoscopic approaches, which are combined with endoscope and which provide automatization of approach or a certain procedures. Usually, these are cadaveric trials. There are only 3 clinical trials on evolution, 1 on iARMS and on Endofix, but this is something which is actually coming, and there are many research groups across the world which are working on this. In neuroendoscopy, there are so-called continuum or snake-like robots, which include concentric tube robots and tendon-driven robots, so flexible robotic-guided endoscopes, which can then be navigated through the ventricular system. And this is how it looks. There are only several case reports and case series on this, but this is something that many people are working on. In pediatric patients, you see that in 2003, we had publications with robotic-assisted endoscopy techniques for example, fenestration of cysts, but this is something which really did not develop from those times. But I think as the robotic neurosurgery develops on itself, it will also find its place in the pediatric neurosurgery. So in skull-based, limitations are size and angulation capacity of the robot, lack of drilling components which prevent fully robotic procedure, and costs. And advantages are improved lighting, 3D visualization, replication of gesture-based movements, and ability for dexterous movements which are constrained by small operative corridors. First robotic assisted coiling was performed in Toronto in 2019. Now we have 2022, and you already have 4 robotic systems which are approved to use for coiling. And when we go from the macro to micro, then you have nanotechnology, which is at nanometer scale that can be used in the real world, 1 to 100 nanometers. Well, you have to know the DNA strand measures 2 nanometers, so extremely small structures. And nanorobotics refers to design and creation of robots at the molecular cellular level, which access to all the human body performing procedure at a cellular level. This is something which neurosurgeons, normal neurosurgeons are not going to do very quickly, but this is also something I just wanted to mention to give a perspective. Where are we going? There are neural nano 3 types of transdermally introduced robots. These are mostly experiments on mice and rats, but we expect, or the people who use this expect, to have the first human experiments in the following 10 years with endoneural robots, glio robots, robots. Exoscopes, robotic guided exoscopes have also found their place in microneurosurgery, and we've come a long way from microscope in 1957 to the EOS 3D exoscope system, which is used in several clinics, and we have now a recent publication on the evaluation of the first cases here and in Alabama. And finally, for peripheral nerve surgery, it has been used for brachial plexus reconstruction, peripheral nerve tumors management, decompression, or peripheral nerve harvesting. So are we ever going to have completely autonomous robots where treatment is not universal, every patient is different, and adjusting movement and demand is not yet possible? For time, it provides stereotactic assistance or equipment positioning alone. And we work now on addition of subroutines, wound closing, clamping, and basic manipulation. This is a paper from World Neurosurgery 2 years ago on experiments in University of Washington team who are working on an autonomous robot, which is conceptually called artificial intelligent neurosurgical robotic assistant. So you would have an assistant who would be able to follow the surgeon and who would actually replace a first or a second assistant at certain procedures. So future of dependent systems will rely on the miniaturization of the tools and incorporation of curved endoscopic ports, and the shortcomings of small parts relate to their flexibility. We will probably have several small robotic arms to assist two control hands to accommodate the limited forces that they can apply. For example, surgeon would control 2 of these arms and the other arms will be programmed to assist the surgeon. You have also this development with artificial intelligence and the Internet of Things in neurosurgery with OPLink monitors, IoT, and SCOTs. And all of this will make it possible that you sit in your home in Germany and perform surgery in Argentina and vice versa, which is actually now kind of starting to happen for functional neurosurgery. You have also a group of surgeon supporting robots. We always say that surgery is an art and not a science, and the goal is not to develop robots, but to achieve better results using robotics technology. And you have an I-arms, this robotic arm on the left side, which is made to eliminate the tremor and fatigue of a surgeon. And you have, for example, Argelis, which is a surgical knee rest, which supports surgeons' lower limb in maintaining a near standing posture, very good and important for spine surgeons. This appeared 2 days ago, a new publication on brain-computer interface, which is assisted by robotic navigation. They have put robotic-assisted brain-computer interface in a tetraplegic patient, did a stimulation, and managed to regain some of the motor function in the hands of this tetraplegic person. Also one report from China. So the future is now. You have first ever 5G remote brain surgery to put the DBS in a patient who was 3,000 kilometers away. So surgeon and patients were 3,000 kilometers away. This is this press release on the left side. On the right side, you have robots which have now largely assist paralyzed people, for example, to control the robot waiters at the cafe. You have a large development of robots, not only in surgery, but as everything is connected, you have a lot of development of robots in entertainment or in industry or in architecture or in buildings, which then kind of transfer to medicine. This is Hinotori. This is from Medicaroid robot-assisted surgery system. There are currently no implications for neurosurgery, but I know that there are some attempts to implement this very high-end newest robotic systems for neurosurgery too. You have also work groups, for example, Duke Robotics Clubs, who worked on automated tumor resection, who tried to develop a prototype of an automated brain tumor resection that uses laser ablation and who does robotic-assisted laser resection of gliomas. You have also recent development bionauts, and there is a big question: will robots replace surgeons? We had in 2022 first laparoscopic surgery without any human assistant in Johns Hopkins. So one can say never bet against innovation and never bet against technology. And when you see this press release from Germany, from the States, from Korea, Japan, China, you see that the robotics is currently exploding everywhere. But on the other hand, never bet against the human nature. And when you see this press release, you see that robots are already being blamed for some adverse events which are happening in the OR. So I think, as with any technology, it is going to be with a great resistance and with a lot of try and fail moves in the next years. But robots are there and they are here to stay. So are robots our friends or our enemies? I think we are now think of them more as a friends or as a certain help, but not as the help which we need and which we would like to help. But they are hopefully going to stay our friends, and it is hopefully going to be, as with any technology, available in the entire world. So thank you for your attention.
Thank you, Mirza, for wonderful lecture, and you introduced all of us about current trends in robotic surgery. And I congratulate for your papers which you published. Are there any questions from the audience? Professor Kato, maybe?
Well, thanks so much, Mirza. Also, you mentioned about the Hinotori is from Japan. So we studied the robotic surgery in many fields. So I think the viewpoint of the spinal surgery, I think that's advantage with robotic surgery is especially for the elder person. So maybe accurate, so no tremor, and very demarcated the lesion that you can extract with the robotics. Is it correct?
Well, for now on, we can use robotics in spine surgery only as an instrument holder to put a K-wire in a pedicle screw. That's the current application. There are groups who have put some cages using robots and who put pelvic and iliosacral screws. So it mostly revolves around screws. There are some groups which work on cadavers and laboratories which now try to construct an autonomous robot which can resect a certain lesion without any help. So the robot should be able to identify a certain lesion and a metastasis or a tumor and to do the automatic resection of that. But this is only on experimental level. There are no clinical applications for that.
Okay, thanks. So does it reduce the surgical time?
Well, actually, it reduces the time you need for implantation of screws. So screw time is lower, but operative time is longer than for the conventional surgery, because the preparation of the field, installation of the robot, technical issues, control scans, it is, I think, double the length of a normal spine surgery.
Thanks so much, but it's congratulations because it's the future, the surgical tools, I think. We learned a lot. Thanks a lot.
Thank you.
Ari?
Thank you, Professor Kato and Mirza. Great. Mirza, is it necessary to use O-arm in screw placement in the technique which you showed, or it's possible to use it with the navigated C-arm to 170-degree C-arm?
You can use it also with C-arm, with O-arm, and with ICT. With everything which gives you which you can use for navigation and which gives you the 3D reconstruction.
Mm-hmm. Good. And also the other question is, what do you think, how much these neural techniques and neuronavigation influences the education of the young resident? So if you know, when we were residents, you had to take measures, etc. Of course, we are using neuronavigation now for 10 years in our department, but how it's going to influence the way of thinking of new generation in terms of robotics?
I'm not sure this is going to be only good for us, for our residents and for young surgeons, because I think we already rely too much on technology. When you do your whole life navigation in cranial neurosurgery, for example, at one point you don't know where the tumor is before doing a navigation. You lose that anatomical understanding of things. So I think it's important for our education and for residents to have both of these techniques applied, to know the both things, to put a screw with a fluoroscopy and to put a screw with a navigation and to put a screw with a robot. We had a resident in our department who has never put a pedicle screw in his life. We gave him the robot and he has put 4 perfect screws with a robot. So I think this restriction of working hours and this attempt to kill neurosurgery with diverse restrictions, for that it is good, because the patients are not going to suffer on the education which is becoming more and more suboptimal. But I think that we should try to maintain our goal as teachers and educators and to try to provide education on all possible techniques, because robots is not going to be in 10, 20, 50 years in every department. And I think you need to use the best technology which is available to you, but you also need to be acquainted with technologies which are, so to say, less good or less in, but which can be equally good for a patient.
Good, thank you. I have many other questions for discussion, but maybe when we see each other, because we have to respect our timetable. Thank you.
Okay, thank you.
Next speaker is Dr. Dragan Jankovic from University Hospital Mainz, Natural History of Spinal Meningioma. Dragan, are you here with us? I see you as a panelist.
Hi, Adi. Yes, I'm here. Do you hear me good?
Yeah, we hear you, but we don't see you. Currently the video is off.
Okay, what? Just a minute. Oh, here.
Oh, now we see you. Welcome.
Thank you very much. Respected colleagues, it's my pleasure to be an honor to be here at the third ACNS Bosnia and Herzegovina webinar. My name is Dragan Jankovic, and I am a neurosurgery resident here in Department of Neurosurgery at the University Medical Hospital Center in Mainz in Germany. My topic today is about natural history of meningioma. We all know that spinal tumors are classified as extradural and intradural in relation to the spinal meninges. Intradural tumors can be further subcategorized into extramedullary and intramedullary spinal cord tumors, and meningioma are the most common extramedullary intradural tumors.
Dragan.
Yes.
Dragan, please, could you share your screen? Probably you have the presentation.
I don't see, sorry.
Just do a screen sharing, please.
Yeah, that's good. Just full screen. Great.
Oh.
That's it. Thank you.
You see it?
We see it.
Okay. As I said, I'm a neurosurgery resident here in Mainz, and today my topic is about natural history of spinal meningioma. Spinal tumors are classified as extradural and intradural in relation to the spinal meninges. Intradural tumors can be further subcategorized in extramedullary and intramedullary tumors, and spinal meningioma are the most common the most frequent extramedullary intradular tumors. Some things about history. The term meningioma was originally proposed by Cushing, and the first operation of spinal meningioma was performed by Horsley in 1887. The spinal meningioma count less than 25% of all primary spinal tumors, and about 25% of all intradural spinal tumors. They are far less frequent than intracranial meningiomas, accounting for only 1.2 to 12.7 of all meningiomas. Most meningiomas occur sporadically, but there is a well-known association to the neurofibromatosis type 2, and it is estimated that up to 20% of patients with neurofibromatosis 2 will develop spinal meningioma, which might even appear early on in the life. Spinal meningioma are benign, slow-growing tumors. They can affect all ages, but they are most common between 40 and 80 years of age. Here we have a female predominance, which has been explained through the role of sex hormones on the tumor growth, and meningioma often carry estrogen or progesterone receptors, suggesting that breast cancer and also pregnancy is a potential risk for tumor growth. And also exposure to the high dose ionizing radiation is also associated with early onset of spinal meningioma. When we talk regarding to the pathology, spinal meningioma arise from arachnoid capped cells within the dura mater. They are typically solitary, slow-growing, with lateral expansion into subarachnoid space and non-invasive into a normal tissue. Very important is that, unlike to intracranial meningiomas, spinal meningioma do not penetrate the pia. Also, with expansion of the end plaque and infiltrating grade 2 and grade 3 meningioma, which have a more extensive tumor matrix and infiltrate the surrounding tissues. Macroscopically, they appear smooth and fibrous. Their classification is well known. According to the World Health Organization, we have 3 grades, 3 subtypes that generally reflect the rate of growth and a potential recurrence base of cytological features. In spinal meningioma, more than 90% are grade 1, and grade 2 is about 6%, and 2 or 3% about a grade 3. When we talk about clinical feature and symptoms, it's important to say that they may produce neurological deficits and pain related to local compression of the spinal cord, nerves, and surrounding structures. Clinical symptoms depend on the exact location of the tumor, and the slow-growing nature of the tumor contributes to a longer duration of symptoms before diagnosis and treatment. And then we have that the mean duration of the symptoms in patients are from 1 month to 3 years. Focal pain is the most common presentation symptom of spinal meningioma, followed by sensoric and motor deficits. Also, bowel and bladder dysfunction may also occur, but less frequently. In our daily practice, here in Mainz, we used a few scales, preoperative, postoperative, and there are different scales for grading clinical and functional status of the patients. And at the end, there is no consensus which scale is the best. So in our clinic, we use the Karnofsky preoperative, we used McCormick, and we use Frankel score. Regarding to diagnostic, MRI is a method of choice for spinal meningioma. On MRI, meningioma are well circumscribed with broad-based Dura attachment, and MRI at the end defines tumor extension and tumor limits with surrounding neural structures, and is extremely important for preoperative evaluation, for surgical mapping, confirmation of resection adequacy, and also for follow-up for tumor recurrence. Something what we see more often in intracranial meningioma is dural tail sign. So in spine meningioma, a dural tail was seen in about study said 52 to 72% of patients, and the dural tail sign is not specific for spinal meningioma, and it could be identified with another intradural neoplasm. We have published the dural tail sign in case of multiple intradural extramedullary metastasis for nasopharyngeal carcinoma, and we also have one case with intradural extramedullary capillary hemangioma. So it's not specific for a spinal meningioma. But ginkgo leaf sign is something what is highly specific for spinal. The ginkgo leaf sign has been described as useful MRI sign in distinguishing a spinal meningioma from neurogenic tumor. For example, spinal schwannoma. It has been seen on T1 imaging on axial post-contrast T1 with the leaf representing the distal spinal cord pushed to the one side of the thecal sac by the meningioma, and the stem probably representing the stretched denticular ligament. Another characteristic of imaging feature of spinal meningioma is the classification. Can be detected on CT, can be detected on MRI. When present on MRI, may produce dark T2, dark signal on T2 MRI images, and classification of the spinal meningioma was classified as complete, partial, and absent. And here in the table, we can see that that's one paper from Louis and colleagues for a few years ago. They investigated the differential diagnosis of spinal schwannomas, meningiomas, and found that 58% of meningiomas showed classification on a CT scan. What we do when MRI is contraindicated, CT myelography may be useful for identifying intradural pathology. Here we have arachnoid isolation sign when intradural tumor is separated from the spinal cord by contrast in subarachnoid space. What with preoperative spinal angiograms, it's recommended by few authors to locate the anterior spinal arteries and detail tumor vascularization, particularly for anterior located spinal meningioma, correspond to a great surgical risk. On the other side, spinal meningioma are very vascular lesions, and a preoperative spinal angiogram with embolization may decrease the risk of the intraoperative bleeding. Before the era of MRI and advanced neurological diagnostic, differential diagnoses included multiple sclerosis, syringomyelia, pseudotumoral herniated discs. Today, the primary differential diagnoses are schwannoma or neurofibroma, typically located anteriorly, tendency for multiplicity, not associated with broad dural base, and more common seen with nerve sheath tumors is neural exit foraminal bleeding. When we talk about location, the most frequently involved localization was thoracic region, followed by cervical and lumbar region. And regarding to dural attachment of the spinal meningioma, predominantly localized laterally, 35, and ventrolaterally, 29%, determined by preoperative MRI, in addition to 9% of patients with ventrally located spinal meningioma. The dural attachment was ventrally to the dentate ligament of the spinal cord in 73 ventrally, and only 27 dorsally. Treatment. The primary treatment option is, of course, surgical resection with goal to achieve a complete tumor removal, spinal cord decompression, avoiding further neurological deficit with low rate of recurrence, according to study 1.3 to 6.4, and associated with significant improvement of motor sensor deficits and bladder dysfunction. When we have a tumor, incomplete resected spinal meningioma or recurrent, radiotherapy is the next step. Simpson grading in the surgery of the meningioma, Simpson grading is used to describe the radicality of tumor removal and to predict the risk for tumor recurrence. The question is whether Simpson's grade 1, which includes complete removal of dural attachment, should be the goal of spinal meningioma surgery, remains a topic of debate. The Simpson scale also address the removal of coagulation of affected dura, and aggressive removal of the dura may reduce the risk of recurrence, but increase on the other side the risk of spinal cord injury and of post-operative leakage of cerebrospinal fluid. A few things about complications. So the most common complication are one infection, CSF leakage, and cardiopulmonary complication. In our last study on 130 spinal meningioma, recently published, also we have hematoma, post-operative wound hematoma in 2%, CSF fistula in 1.6%, and meningitis in 0.8%. That's from our last study. So preoperatively, we categorize all our patients according to McCormick, and we have neurological improvement at the discharge in 46, remain unchanged in 52, and worse in 2% at discharge. At the early follow-up, that's the B B picture, we have the proportion of 45, 28, and 5. And at the last follow-up, we have 67 improved, 70 unchanged, last to follow up 12 and 4 for worsening. That's the same patient here in the middle. The picture with 5, that's the patient with complications and the patient with recidive. Time to surgery, tumor area and degree of spinal cord compression significantly predicted post-operative improvement in a modified McCormick scale, and also our multivariate analysis showed that Frankel score is a significant predictor in predicting the likelihood of these disease worsening, and patients with higher scores preoperatively had a 9 times higher chance of disease worsening postoperatively. Recent studies show that surgery was associated with significant improvement of motor deficit, in sensory deficit, gait disturbance, bladder dysfunction, and pain. Of this, bladder dysfunction was the symptom that most often improved in 76 patients, followed by pain, 53, and gait disturbance followed by 51%. When we talk about recurrence, that's one literature review from colleagues. We can see that recurrence rates range between 1.3 and 14.7, with mortality up to 4%. And what is very good, complete resection range between 82% to 97%. What is potential risk for neurological deterioration? Tumor calcification, anterior dural adherence, infiltrative meningioma, tumor adherence to spinal cord, worse functional grade at admission, prolonged presentation, so delayed diagnosis, and older age. We use intraoperative also neuromonitoring for our patient, and we present our patient preoperatively on tumor conference, postoperatively when we have grade 1, we made a 3-month follow-up, and then 6 months, 1 year, 2 year, 5 year. That's all depending on surgical resection and according to WHO, right? Neurological status determine further follow-up and also imaging. And at the end, that's a quote from Cushing and Eisenhardt, that after the surgery, that is one of the most gratifying of all procedures. In the last few decades, a better understanding of relationship between patient status, outcome, tumor pathology, location, ossification significantly improved the surgical management of spinal cord meningiomas. Thank you very much. I think that's the end.
Thank you, Dragan. Do we have questions from the audience? Dragan, I have one question. How does this calcification of the tumor involves, how it's involved in a worse outcome, which you have showed, and which is the natural history of already calcified meningioma, even intracranially or intraspinally? Is it gonna grow, or it's actually bordered after?
I think, thank you. That's a very good question. Thank you very much for that is a very small samples that the colleagues published. In our group here, we have just a two or three classifications. So because of small sample, we cannot statistical analysis make for calcification. But the colleagues said that tumor calcification can predict, but the series that I found, that's all are case report or with maximum of 6 patients with tumor calcification. So I think this is very very hard to say that the conclusion about tumor calcification and deterioration. Yeah.
Okay, thank you. Any other questions? So if not, then we can move. Next is my topic. Do you see it, please?
Yes, you are here.
Okay. Is it? I believe it's full screen. So
yes, now it's fine. Yes, Adi.
Thank you. Thank you, Ibrahim. So it's my pleasure to share my topic with you. My name is Adi Ahmed Spahic, and I work in Department of Neurosurgery, Clinical Center of University in Sarajevo. My topic is Chiari malformation treatment. Of course, I'm not an expert in this field. I'm a young neurosurgeon, 3 years experienced, and I have a couple of cases which I will show. And I believe that you who are more expertise in the audience can help all of us to learn something. Let's go for short background. Chiari malformation represents variation of hindbrain development, which finally represents in protrusion of the posterior fossa elements through the foramen magnum in general. Early descriptions are found at least as far back as the 19th century, and Hans Chiari deserves the bulk of the credit for the first series of autopsied patients. In classification, we know that we have from Chiari 0 to Chiari 5, but the Chiari malformation, which we found mostly, is a Chiari 1, Chiari 1.5, and Chiari 2. Luckily, Chiari 4 and 5 are quite rare, but if they happened, we will have probably a bad outcome because of the other malformation. In pathogenesis, we have a couple of theories, which I will not take time for this because of the respect of the time of the webinar, but it's very important to mention that development of arachnoidal layer presents a very, very important cause of the Chiari. So in a clinical presentation, depending on the type of malformation, we have in major three types of symptoms. Symptoms which comes from the CSF obstruction, symptoms from the compression of brainstem, cerebellum, or cranial nerves, and spinal cord dysfunction, including syringomyelia. So all of these symptoms can be actually mixed during the clinical image which we see in the patient. How we decide on the treatment? First, we have to know in the natural history of Chiari that 93% of patients who are stable or they don't have worsening of the symptoms will not need a treatment. For the surgical indications, mostly what we look at the patients is does the patient have classical Valsalva-induced headaches, patient who has associated syrinx, and patients with neurological sequelae associated with pathology of the foramen magnum, cervicomedullary junction, or lower cranial nerve dysfunction. So diagnosis, of course, we use MRI. This is a type of these Chiari 0 with no protrusion of tonsils, just a syrinx. This can be Chiari 1.5 or 2, depending does the patient have MMC or the patient doesn't have it. So we can see tonsillar protrusion, some medullary kinking, changes in the corpus callosum, syrinx, etc. So in short view of neurosurgical options, there are many studies which has been showed, but in general we have a couple of options. It's just posterior fossa decompression, which is extradural procedure, posterior fossa decompression with duroplasty, posterior fossa decompression with intradural procedure, including tonsillar resection, coagulation, adhesiolysis, etc., minimal invasive subpial tonsillectomy, different shunt procedures, EVT, OC fusion. And when we think about the possibility of treatment, we have always to take in account complication rate. So these are the images from Journal of Neurosurgery Pediatrics. Here is the arachnoid alveoli, which usually closes the fourth ventricle, which should be open to establish the CSF flow. I will also kindly ask as a moderators participants to turn off the microphone because we have many sounds in the back. So I'm kindly asking once more to turn off the microphone, please. Intraoperative intradural exposure of the severe form of adhesions of the arachnoid in a posterior fossa. So in the surgical steps, how we do it actually, many of our surgeons deals with the Chiari. We have the patient put in prone position. The head is elevated for 20 to 30 degrees to decrease the venous pressure. Neck is usually flexed. The incision extends from finger breadth below the external occipital protuberance to the spinal process of C2. We follow the avascular midline plane by monopolar cautery. Bone removal should be 22 to 25 millimeters in wide and height, depending on the surgeon. Sometimes we do a bigger craniotomy, sometimes this is enough. And the posterior C1 is also removed. So now we come to the dura. Some surgeons are opening the dura, some others do not, but we can discuss it later. So this is a first presenting case. This is my recent patient. Before I show his symptoms, I will show you his MRI. So this is the MRI of the patient who had the tonsillar protrusion, syrinx, which goes all the way to TH10, corpus callosum, which is elevated, and some other changes. He didn't have MMC, so this was referred as Chiari 1.5. And what actually we see is that patient has also ventriculomegaly. So there are no signs in each of magnetic resonance scan, no real signs of hydrocephalus. So actually when we see this image and when we come now to reconsider his symptoms, which were bulbar symptomatology, he had severe cranial nerve 11 paresis. He also had the paresis of 7th nerve. He had the walking difficulties and right side paresis. So comparing to this image, clinical picture, and this image of MRI, we decided to go for surgery, for posterior fossa decompression. This is the image from operative neurosurgery, how the patient should be positioned with the tilt, little tilt of the table for 10 degrees to decrease the intracranial pressure. Here is the posterior fossa exposure, C1, as well as part of the C2. From studies which I reviewed, C2 shouldn't be exposed because if we cut muscles, some ligaments at the C2, there is increased chance of instability, post-Chiari instability. So for my future cases, I will probably go for just C1 exposure. Here is the intraoperative video. This is the exposure of posterior fossa, and the dura is opened under the microscope. There is a very high pressure of CSF after opening of an arachnoid. This is the Y-shaped opening of the dura, standard with the dural tuck-up sutures. And now we can see tonsils, which are below C1. Here is an opening of an arachnoid. And now we exposed the tonsils first on the lateral side towards the cerebellomedullary cistern. Where we expose and where we cut all arachnoid trabeculus in a vertebral artery, in an accessory nerve, in etc. So we can mobilize the tonsil below the from the lateral side. Now we are coming towards the medial side. We can see severe form of adhesions towards the branch of the pica, and those branches are, this artery is released, so we can pull up the tonsil. Once we have done the release of the artery, we can approach to the inferomedial side of tonsil to explore more and to open the arachnoid widely. You can see those membranes here, how those membranes are covering and closing the CSF pathway. So with a sharp and blunt dissection, with the movements of the mostly by Yashargil, you can open CSF spaces and establish normal CSF egress. And here is how it's going to look at the end of this procedure. So we can see spinal accessory nerve, pica, vertebral artery. Now we come towards the contralateral side. Some small feeding tonsilloapical branches may be coagulated, but you have to be very careful for the pica, which lies below in cerebellomedullary fissure. So now we come towards the contralateral side, release the adhesions, and explore the pica in a cerebellomedullary fissure. Those membranes are opened, same on the other side as we have done it in the previous. On the left, on the right, this is the left side now. And part of vallecula towards the Magendie should also be opened, as in this case. So after CSF is restored, we do a tonsillar elevation by the 7-0 stitch. So I don't personally coagulate the tonsil, because with this technique, I believe that the tonsils may be pulled back to the level of the foramen magnum, so we don't have to actually coagulate them too much. This is just an apical coagulation. And we can see how for the inner layer of the dura, tonsils are from here. This is the C1, this is the foramen magnum. Now we elevated the tonsils back. And here is the post-operative patient in intensive care unit. So the wound looks good. Immediately there was improvement of accessory nerve of the patient, as in this case. And there were no more ataxia. The probe nose, finger to nose is normal. You will just see the patient walking, and you will see how the patient stands and the atrophic changes in the hands, because this was a chronic pressure in this patient. So you can see the hypertrophy of the right hand, as well as the tenar and hypotenar region. So unfortunately, this patient had urinary infection, and he was in febrile state. He had vomiting. For 12 days, we had a good wound without collection, and this is the same patient after he had a CSF leak, which is the major complication of these intradural procedures. There is not just a problem for the CSF collection, there is the problem of the pressure. So we decided at the end not to go to the revise the wound. We decided, because of the first image, if you remember, we decided to go for a VP shunt. And the patient went well. This is the other case of Dr. Almir, other young neurosurgeon in our department, 17 years old female with Chiari 1, occipital headaches and ataxia. Similar technique, great technique of Dr. Almir, who performed posterior fossa decompression, intradural exposure. Same can be seen here after exposure of the fourth ventricle, and those adhesions have to be released again as in the previous video. So I will just skip it a little bit. So the CSF pathways are opened sharply and bluntly. And what is here done is that the coagulation of the tonsils have been performed without tonsillar elevation, with actually same result. So I will just skip this part because you've already seen how we do it. Now we come to the final part. This is coagulation. Now you can see the tonsils, which are at the level of the foramen magnum. This is the C1. Everything is fully exposed. And here is the Dura patch for the closing. Post-operative CT scan, the patient went well. This is the opening, no CSF fistula, and this patient went well for the end. In conclusions, the ideal treatment for Chiari malformation remains a challenge with many different approaches, which offers possible favorable outcome. However, most neurosurgeons prefer intradural procedures, including resection of the tonsils. All potential complication and benefits of the approach should be taken into account when deciding on a surgical option. Although research is still ongoing in the field of the best possible treatment, institutional practice and personal experience play an important role in making a decision. And thank you from Sarajevo.
Thank you, Adi. Nice presentation, nice video. Originally, you did it. Is there any question from the audience? Yes, Professor Bosniak from Ljubljana, please.
Thank you for a nice presentation and a good technique. But my question is about recurrences. Did you experience any recurrence in your cases?
Thank you, Professor Bosniak, for a question. As I said in the beginning, I had only a couple of cases, and until the present date, I didn't have. I had this first complication with this CSF fistula. So I'm still waiting for the post-operative MRI of last two cases because those are the recent cases which we have performed. So by now, by far, but I tell you it's a small number of cases, I didn't have recurrences. But I believe that recurrent Chiari can be more tricky to treat because of adhesions of the arachnoid after surgery.
Okay. I will just continue this comment because in 30 years of my practice, I also didn't have recurrences. But in the one last case, when I was doing the same technique as always, and it means decompression, duroplasty, apical coagulation, this patient had a recurrence, which was developed bulbar symptomatic. First he had ataxia, now he had bulbar symptomatic, and one of the reasons I think is sleep apnea. So we didn't know that in this 27 years old guy who was a stronger construction, he had sleep apnea. So I believe that this could be one of the reasons for the recurrence, and maybe we should treat sleep apnea first, because this can be very harmful in conjunction with CSF leak, as you said, it's most often. So here was a CSF leak, subcutaneous fistula, and also this recurrence. And on CD scans, we see that the bones come very close to the clavus, and there was some kind of brainstem sagging.
It's same with this patient. He also had a sleep apnea, and we actually had this complication 12 days after surgery. But as I was reviewing the articles, I don't know, how do you do your closure? I made a mistake in my case. I closed it with Dura. I believe that the craniotomy was too large, and I didn't use adipose tissue as a fat graft. By the article of Professor Arnautovic, who will join us later, he had a 3 CSF fistula after which he used adipose tissue as a patch in a wound. So then after, he didn't have any complication in more than 100 cases. So actually, I reviewed my case many times, and the other thing which I think that I made mistake for CSF fistula is that I should consider high CSF pressure. As you saw in the beginning of the video, there was a high pressure of this CSF, so I should reconsider the option of the shunt early. Okay, thank you. Any other questions about Chiari?
I think that Dr. Kale wanna ask something. No? You want
Hello,
to something? Yes, we hear you.
Yeah, I was just wanting to know the techniques regarding closure of the craniotomy so as to prevent the CSF leak.
I'm sorry, Dr. Kale, I didn't catch your whole questions. Please, can you repeat?
Yes, sir. So I wanted to know the best method for closure and to prevent the CSF leak. Most of these patients, we always get CSF leak.
Okay, there are some different techniques. We use a Dura here. You can use Gore-Tex. You can use a pericranial flap or even fascia lata if you need it, but it's not so usual for posterior fossa. What is mentioned, as I told to Professor Bosniak, it's mentioned that adipose tissue from the adipose fat graft from the abdomen should be used to fill the gap, and also dural exposure shouldn't be too large. What I really like in some of the techniques is a linear incision of the dura. For example, MIST technique in China and in Italy, how those colleagues do it. So they use a linear incision instead of the Y-shaped incision. Whenever you do the Y-shaped incision in posterior fossa, some of the dura retracts, and there is a problem to close it. So if we go with the linear incision, even if the arachnoidal, if we can put arachnoidal stitches, it would be much better to decrease the chance of CSF leak.
Okay, sir.
Yeah, maybe one comment. Is there any question? Is somebody wanna? Yes, please. Yes, Dr. Almir.
Okay, thank you, Adi, for your nice presentation. Just maybe one comment. I agree with you that I also talked with the Professor Arnautovic, and I'm sorry he's not here now in this discussion, but I think that the fat tissue is maybe the most important thing to prevent the CSF leak, because there is still some controversy in these types of surgery in the Chiari malformation, whether only bony decompression in some cases without syringomyelia, but in our institution we usually perform the bony decompression, duroplasty, tonsillar coagulation, elevation, and so on. So I think the fat tissue maybe is the best option, and not only to prevent the CSF leak. There is also one important thing to prevent in this type of patients, to prevent the post-surgery, post-occipital headache, because as we know, after the craniotomy, in some cases, we reveal the pressure, but because of the adhesions of the dura, muscle adhesions of the dura, some patients may continue with the headache, even after decompression. So the fat tissue will prevent the CSF leak and also will prevent the adhesions of the muscles, suboccipital muscles to the dura, and prevent this post-surgery headache. So I think that maybe the fat tissue graft is the most important to prevent the CSF leak and prevent the post-operative headaches.
Okay, Almir, thank you. Any other comments? Just one comment I would like to say at the end, maybe if there is no other questions. Almir and Adi knows, usually I prefer doing the very low craniotomy, just 1.5 or not more than 2 centimeters of occipital craniotomy, and yes, opening the dura in the horizontal fashion. And the most important, probably one of the most important things, is to open the Magendie and dissect the arachnoidea from the Luschkas, because when you allow the CSF to go up and down through the Magendie and lateral foramina to the fourth ventricle and other arachnoidal space, you will probably prevent the CSF pressure, because you will improve the communication in the CSF spaces. And also concerning the fat tissue, yes, it's good reason to put it there, but I think so it should be obligatory for the children, because there is no enough tissue, soft tissue in the occipital region comparing with some big guy who has the muscles there, and you can close even much better, and then it's option, because this situation for the prevention of the occipital pain. However, so my recommendation, open arachnoidea, not just resection of the lower part, lower third of the tonsils, open the arachnoidea also, and then in the young guys and children, put the fat tissue from abdominal region, or even make another incision up to the main one and take the pericranial or periosteal tissue and put them even better than the Dura autograft. It's much better for the closure. Thank you. Adi, you can continue with.
Okay, if we don't have any, thank you for comments and questions. If we don't have any other, we can proceed with the next topic. Next topic should be by Professor Salman, why aggressive treatment in spinal trauma? Do we have Professor Salman here from Pakistan?
So Dr. Ali, so far I don't see the Salman Shaif. So maybe we can ask Dr. Inoue, because
Okay.
I don't see the Mehmet Seli as well.
Me too. So please, Professor Tatsushi Inoue, a less invasive craniovertebral junction surgery from a spinal neurosurgeon standpoint. Please, Professor Inoue, you can start your lecture. Professor Inoue. Professor Inoue, are you here with us?
I think maybe he's not with us now. So can you ask someone else?
Yes, sure. Next is Professor Zileli. I don't hear you see also Professor Zileli, and we have a lecture by Professor Arnautovic. So I believe we still wait for Professor Arnautovic to connect.
It's probably the problem of time zone now is 4 a.m. in the United States, so he will enjoy with us later on. I think so.
Okay, then while we wait for Professor Inoue, maybe we can discuss more if anybody is interested in some of the topics which we have showed. I'm interested. Sorry, please, Ibrahim, continue.
Yes, I would like to ask Professor Bosniak. His lecture this morning was very interesting, and I know his surgical experience, and I like it very much because he make actually a shift from the classical neurosurgery, let me say, in his department. I was a fellow there for maybe 15 years ago, and he made actually very a large step forward, introducing the minimal invasive and endoscopic surgery. So at that time when I was there, it was actually early beginning on using the endoscopic surgery there, and I learned the pituitary with him and learned some tricks from him. And I would like to ask him, when is the time to start to use the endoscope? During the residency, senior residence, or I know that as we are growing up, aging, and we are trying to escape treatments, but you are the good example that even if you have some kind of, let me say, misunderstanding for some new procedures, I think so you had at that time, you can push yourself forward and introduce new techniques. So for the young residents, young guys here, please, could you say us a little bit about your way, how to introduce the new part of neurosurgery in your department? You was pioneer of that in Slovenia, I think so, in endoscopy.
Yes. I think that when to start endoscopy should be early, but it should not be, I would say, intense. So first it goes with the assistance. So now I have 3 candidates who are very eager of endoscopy, and they are assisting me by holding the endoscope. This is a dynamic way. I never used a mechanical holder. and I'm always having young assistants with me. And I think this is the best start to learn. And there comes another aspect, that these young people then said, oh, professor, he's having only endoscopy. So this is very interesting that they would like to do the trepanation, they do like to do classical microsurgery. So I solved this by delegating them to other my colleagues to assist and to learn. Because when you are, I think, more than 10 years of neurosurgery, when you are specialist for 10 years, you start mastering some procedures and you have some high level of results. So it is very difficult to start a new way. I had a similar problem to switch from microsurgical endonasal to endoscopic endonasal. So it took me at least 2 years after first attempt in endoscopic and then switch from microscopic to endoscopic solely. So I somehow understand that some older colleagues who are in neurosurgery for 10, 15 years, they can't switch back. So I think there should be a parallel education of young people, and that residency should include endoscopy first by assisting and then performing some part of the surgery, like endonasal part, drilling, vomer, which is quite thick, and then they get some impression, how is this to work in a small confined space. Also, I think that endoscopy teaching and learning, it makes you a better neurosurgeon then, because in such small place, you work in endoscopy, there working with open craniotomy is a royal free space. So it makes you better because you get also some patience. You can calm yourself working in content space, and this is very valuable to have for microscopic surgery later. So I think there are benefits for early learning of endoscopy, not like a course, but like a continuous growth on both parallel parts.
Thank you for that, for explanation. May I be a little bit direct and unpolite and ask you, can you accept one of our young guys from Bosnia for short fellowship, for example, with you in Ljubljana for endoscopic surgery?
Of course, no problem.
Thank you. I will send you a message later on privately after I make communication with my young neurosurgeons club. Adi, how is going on?
We are still waiting for Professor Inoue. May I kindly ask Professor Kato to remind Professor Inoue about our...
Yes, I did.
You already did. So
yes, I did already. So he is preparing now.
Good, because we are waiting for also for the other speakers, which we don't have here. So
he is ready.
Oh, it's here.
Okay, before the Dr. Inoue started, I would like in front of Professor Kato and Bosnian National Society invite all of you to our fourth webinar, ACNS Bosnian webinar, which will held in February 2023, 18th February. So we will send you emails and invitation also to be a participant. Thank you. Thank you. I think so. The professor, it's already here.
Yeah, thank you. Can you hear me?
We hear you. We hear you, Professor.
Can you hear me?
Yes, yes.
Yes, we hear you.
Yeah. Today, I'd like to talk about endoscopic ventral craniovertebral junction decompression with a special reference to Chiari malformation type 1 with vaginal invagination. How do you treat this case? This case is 50 female presented with dizziness, ataxiate in 2010. She had underwent ramen magnum decompression, but symptom and sign persistent, and additionally, she developed sleep apnea syndrome in 2014. She was referred to our hospital, and we planned the next strategy. This case was first we planned. We think the most golden standard is occipital cervical fixation. This case was published on Journal of Neurosurgery, Spine, and reviewer commented this case should be occipital cervical fixation. However, occipital cervical fixation is very invasive because the motion segment is impaired. First, we performed C1 C2 destruction. Ventral compression is decompressed by C1 C2 destruction. This method was developed by Professor Goel. By destructing the facet, we used cage instrument. Ventral compression could be reduced and decompressed indirectly without surgical removal. First, we chose this method. However, patient symptom improved transiently, but delayed neurological deterioration had occurred. So, additionally, we performed anterior ventral decompression by using endoscope. Why direct decompression? As you know, pyramidal tract present most ventrally. Motor function or clumsiness would be impaired by direct decompression. In case ossifixation or C1 C2 facet destruction is insufficient or is followed by delayed neurological deficit. Using endoscope, we can go and back to nasal or oral route, especially for highly positioned pathology if necessary. However, using microscope, limitation to the rostral surgical view because of high positioned odontoid process or micrognosia, limited mass opening, and so on. After publish of this case, the letter to the editor was offered to the Journal of Neurosurgery Spine from Indians. And this case, in this case, Goel's method, C1 C2 destruction was performed first, but delayed neurological deterioration had occurred. Respiratory dysfunction had occurred, so they performed anterior decompression by odontoidectomy. He or she had recovered completely. This suggests the anterior decompression is very important to improve the symptom. If posterior or occipital fixation is insufficient. Compared with microscope, endoscope is very close to the target pathology with more enlarged and more fine, brighter surgical field. In addition, we can look up more intensively using endoscope than microscope. To look up more rostrally, we can move from oral to nasal route exclusively using endoscope. Three sagittal plane corridors are suggested. One, superior transcribal route for pituitary region. Two, middle transcribal route. And three, inferior transcribal route for C1C2 region. Take care if vaginal invagination was not present, we can capture it looking down. And if vaginal invagination present, C1C2 present straight forward. And this is our setting for endoscopic craniovertebral junction surgeries. We use also endoscope and microscope with navigation system. Navigation is useful without fluoroscopic control. Endoscope is inserted both transoral and endonasal. The instrument for transoral or transnasal drilling or decompression is just like this. The curette or rongeur is the same as the instrument in lumbar endoscopic instrument. The width or the length is very suitable for craniovertebral junction surgeries. We are using these in lumbar endoscopic surgeries. Micrognathia is very important and effective for indication of transoral endoscopic surgeries, because limiting width of oral is can affect the insertion of endoscope. This is a summary of our indication of endoscopic anterior craniovertebral junction surgeries. Three of five cases Chiari malformation type 1 with vaginal invaginations, and the other two cases tumor, and one case the last week case malignant lymphoma. Approach is first case transoral, combined transoral transnasal. Case 2 is transnasal. And the transoral case is case number 3 and case number 4. In all cases, it's no neurological deteriorations. Follow-up is the 80 months to the latest case, the last week case. OC fixation was performed. Combined posterior fixation, the OC fixation is performed in 3 cases of 5 cases. And the C1, C2 cases were performed in 2 cases. We prefer C1, C2 fixation because we believe motion segment should be preserved at most. And representative case, this is case 2, 37-year-old male, Chiari malformation with vaginal invagination. Chip of odontoid process is beyond maculagar line, 6 millimeters. Macrogonastia is present. This is this case very difficult to access using a microscope. So in this case, for this case, endoscope was indicated or via transnasal route. Left side picture is directory of drill via transnasal route. Target odontoid process is just straightforward to the view. This region is very difficult to access from the oral side. We can show the video. Yeah, superior pharyngeal space. Midline is demonstrated. Middle pharyngeal line is cut and separated. We are now drilling C1 lamina and odontoid process. Retractor is very difficult to place because the space is limited, but we are using suction as a retractor, and the drill itself is also the other side retractor. Sometimes we use endoscope as a retractor. So with that retractor, we can advance into the small space. This is the advantage of endoscope. We are removing the ligament, cruciate ligament, and completing complete decompression. Yeah, now we are comparing anterior approach, transoral or transnasal, comparing between transoral and transnasal approach. The advantage of transoral or approach is inferior limit of exposure is more lower. C2 or C2 disc, C2 C3 disc space is exposed using transoral approach, and the on the other, transnasal approach is the most advantage to reach the rostral side of the region. Superior limit of exposure is more advantageous using transnasal approaches. And another advantage of transnasal approach is very difficult to swallowing disturbance is one problem after transoral approach or transpalatal approach, but using transnasal approach, the problem is very limited, and we can fix the swallowing disturbance using transnasal approach compared with the transoral approach. The detailed anatomy, the reason the swallowing disturbance is preserved using transnasal approach is passivant reach is a keyword to preserve swallowing to prevent swallowing disturbance using the transnasal approach. Using transoral approach or cutting the pharyngeal tissue, the passivant reach is easily impaired. However, using transnasal approach, the reach is easily preserved. So transnasal approach is advantageous comparing transoral approach. We are comparing using the fluoroscopic images, transnasal right side, transoral approach left side. Using transnasal approach is very easy to reach the chip of the odontoid process, especially in case of high chipped odontoid process. The suction is a little bit wide. This is navigation suction. Navigation suction is useful in this type of surgery. My strategy for Chiari malformation is just like this. If basilar imagination is deficient, the simple foramen magnum decompression is okay. However, with basilar imagination, first we perform C1 seat fixations with distractions. Or one-step surgery, it can be possible, endoscopic odontoidectomy with C1 seat fixations. However, after posterior surgery with distraction, delayed symptom had occurred. If delayed symptom occurred or residual symptom is significant, second step surgery would be important using endoscopic transnasal or transoral odontoidectomy. In summary, in Chiari malformation with basilar invagination cases, anterior decompression is occasionally mandatory, although it is not generally adopted because of its technical difficulty. Endoscopic decompression via the endonasal route is a useful option for complex pathology, such as Chiari malformation with basilar invagination. Thank you for your attention.
Thank you, Professor Inoue. Great lecture. Are there any questions from the audience? Okay, so which is, Professor, I have a question. Which is a best case of Chiari 1 malformation? So you mentioned basilar invagination.
Yeah.
That is the, is it the only indication for your approach, or you have some other types of the anomalies in a skull base in a Chiari malformation which you treat by this approach?
Another approach?
Yes. Do you use some other approach, or which is your surgical strategy in these cases?
Yeah. Basically, as I suggested in the flow chart, we perform the basically posterior approach with distractions because simple, less invasive, single approach I prefer. But if necessary, I use endoscopic decompressions.
Okay, thank you for your lecture and your answers. Do we have other questions?
Yes, Adi, please, if there is other, somebody want to say something? Professor Bosniak, maybe, yeah?
How is the closure if you have intradural compromissions? How would you close this? Because this is a low point, high CSF gravity pressure.
You mean the dural impairment with CSF leak?
Yes, yes.
Yes. If I have no experience about the dural impairment, but we are preparing the method. First, we lay some material, example, Duragens in lead. After placement of the Duragen, we place again Duragen on lead. And next, followed by application of fibrin glue. And after that, we replaced spinal drainage.
Oh, okay. This was my next question. Thank you.
Professor Nye, one question more, if you can answer, please.
Yeah.
As we know, there is different approach in schools how to treat Chiari malformation with or without the basilar impression. For example, one of them is Professor Atul Goel, who is sometimes want to say that the instability of occipitocervical connection is the most important reason for the Chiari, also for the problems there. Of course, you are talking about the combination of Chiari and basilar pressure. Previously, today we are talking about the simple Chiari malformation cases. However, I would like to ask you actually two things. First one is how do you actually confirm instability? This is my personal question, and also I think so it's interesting for the young neurosurgeons and residents, how to confirm clinically or radiologically that there is instability. You should put the screws there. This is the one question. And another question is, what do you think, is it really enough sometimes just to stabilize OC fusion? I mean, will solve the problem with Chiari?
Thank you for that question. First, to evaluate instability, actually, we check only on X-ray flexion and extension. Yeah. But on study level or investigations that using traction is vertical instability should be evaluated to more detailed instability evaluations is ideal. But actually, we are evaluating only simple flexion extension injury. Flexion extension evaluation. Professor Goel says the pathology for Chiari pathology, the main pathology of Chiari malformation is C1, C2 instability.
Yes.
And usually only C1, C2 fixation is, I think, sufficient for fixed instability.
Okay. Okay. Thank you. Thank you very much.
Yeah, the second question is, sorry, again, pardon, second question. What is your second question?
Okay, so the profile X-ray in the dynamic means flexion and extension is enough for confirmation of instability. Yeah.
Yes. And, significant OC1 instability generally is not present, we think.
Okay, thank you.
And thank you for your lecture and questions. I believe we should move on. Professor Mehmet Zileli is with us. Welcome, Professor Zileli.
Thank you.
Hi, everybody. It's my great pleasure to be with you. Unfortunately, I am in another meeting in India, Mumbai, and I'm broadcasting from here. My first talk will be on philosophy of minimally invasive spine surgery. I cannot share the screen. The other speaker must.
Professor, please, can you stop sharing your screen?
Yeah.
Thank you. Now you can move on, Professor Zileli.
Yeah. Do you see my screen now?
We do. We see the screen and we hear you well.
Okay, good. So the philosophy of minimally invasive spine surgery can summarize some aspects of our current knowledge and current practice on minimally invasive spine surgery. First of all, this is my conclusion slide. I will show it again. The advantages are short hospital stay, quick return to work, cosmetically better, patients demanded more than surgeons, and less infection rate. However, there are some disadvantages like long learning curve, special instruments and equipments are necessary, tactile sensation and biplanar imaging is an inferiority, complications are hard to treat, more radiation to surgeon, and outcomes are similar to traditional surgery. In general saying, indications are same with conventional surgery, however, no damage or less damage to surrounding tissues. Outcomes are same, but more radiation. If you look at the types of MIS surgeries, image-guided percutaneous, endoscopic, and mini-open are the three types of techniques we use. Probably image-guided percutaneous technique, which is a vertebral body augmentation using vertebroplasty or balloon kyphoplasty, are very well known by many of us, and they are really very minimally invasive techniques. If you look at the indications, MIS decompressions can be done by a tube-guided surgery or full endoscopy. MIS fusions can be done by minimally invasive pedicle screw fixation and interbody fusions. MIS deformity corrections can be done. This is my presentation order. I will start with the MIS decompressions and then go back to 1996 that the Foley and Smith's improvement on tube-guided surgery. You use some dilators, dilate the muscles and then place a tube in 14 to 80 millimeter diameter. And then you can either use an endoscope or microscope. There are many tubes in the market. The first one was introduced by Medtronic Matrix tube, then Storz, EasyGo, and the Stando systems. And there are many domestic or local instruments, tubes in many countries. The table-mounted fixator of the tube allows tubular retractor to move or angulate in different directions. You can sometimes look at two levels with one skin incision only, especially if L4-5 and L5-S1 level is very suitable for that. And you can also do endoscopic or tube-guided lumbar spine stenosis decompressions by making a unilateral approach and bilateral decompressions. You look from one side only, and then you can also decompress the other side. This is a good example of how we can do it. And this is another example. And you can also use a tube for paralateral disc herniations. You can also use it in the cervical microendoscopic discectomy from posterior, 14 to 60 millimeter tube, AP and lateral fluoro. This is one example. And the position and the tube there. And this is the nerve root just underneath the nerve root on the axilla of the root is the disc herniation. What about full endoscopy? Actually, full endoscopy has some advantages because they use a water irrigation system, and then the bleeding control is easier. However, the working channel is 7 to 8 millimeter diameter, and you have to use special instruments. The Kambin has first described the transforaminal approach for disc herniations. Then more recently, Rutten from Germany has improved the interlaminar approach for disc herniations and stenosis. However, if you look at the transforaminal and interlaminar endoscopy, the indications of transforaminal endoscopy is not that much large. It may be 20%. If in very experienced hands, it may reach up to 40%. L5-S1 is difficult. However, in interlaminar endoscopy, indications are larger and L5-S1 is easier. This is on the left, Foley and Smith's tube-guided surgery. On the right, water irrigation system developed by Rutten. These are some steps. Since there is no retraction, you cannot place a retractor there. The end of the tube must be turned to retracted root on that level. So because of that, for the new beginners, the injury to the root and dura is possible. And you can also use drilling, but the drill bits are somewhat expensive, and the baseline instruments are expensive. If you look at the disadvantages, stenosis drilling is harder, steep learning curve, more than tube-guided surgery. Baseline instruments are expensive. In conclusion, tube-guided discectomy may be applied in all forms of herniation and spine stenosis. Small modifications of conventional instruments. Baseline equipments are cheaper and may be applied with endoscope or microscope. The learning time is shorter. Translaminar transforaminal endoscopy are more technically demanding and have restricted usage. What about MIS fusion? First, we must mention about the pedicle screw fixation. As you know, as you well know, the open surgery must retract the muscles too much. If you use Wiltse approach to two lateral incisions, it may be less than a midline approach. But in this case, too much muscle atrophy will develop after surgery. The MIS pedicle insertion may prevent this by placing the screws through the muscles. In this case, you must be very familiar with the AP and lateral fluoroscopic images, radiological anatomy of the region. And you must aim with different angulations to go to through the pedicle and then reach to the body. And most surgeons prefer using a key wire first and then place their screws, cannulated screws, through that key wire. Placing the rod may be more difficult, and to facilitate placing the rod, especially for multiple level fixations, the sextant system was first described by Kevin Foley, who have founded, first developed the tube-guided surgery. Advantages are smaller incisions, less muscle retraction and trauma, less blood loss, reduced post-op pain, and shorter hospital stays. However, disadvantages are potentially longer operation times, longer learning curve, loss of surgeon control or tactile feel, and some surgeons some systems require damaging muscle at non-affected levels and more radiation for surgeons. What about interbody fusion? There are different types, as you know. Many surgeons do not prefer PLIF today because of too much retraction of the nerve root, but TLIF, ALIF, and XLIF may be done by minimal invasive approaches. TLIF may be done by a larger tube, 26 millimeter tubular retractor, by a unilateral or bilateral approach, and XLIF or transpsuatic approach, which was developed by Dr. Pimenta from Brazil in 2003. You can place a very large cage. However, to do that, you must cross the psoas muscle, so then you can injure the lumbosacral plexus. To avoid this, you must monitor the EMG monitor the lumbar plexus, and you need special retractors, very long blades. Indications are from L1 to L4-5. L5 phase 1 is not possible, and grade 1 disc disease, degenerative disc disease, degenerative scoliosis, and aged patients can be indications. And you can also apply indirect decompression of spinal stenosis. You can even correct some deformities, scoliotic deformities. If you come from the convex side and then place a very robust cage, you can correct it. Advantages are no need to mobilize great vessels. Large lordotic cages may be used, easier in obese patients, no access surgeon required, and high fusion rates. However, injury to lumbosacral plexus and EMG monitoring is necessary. Deep working channel and posterior fixation are still necessary in most of the cases. There are some other percutaneous fixations like transfacet fixation or translaminar fixation, which was first introduced by Magyar. This is one example of mine about this. However, there are some other techniques like axial lift to make a L5S1 fusion, which has almost disappeared in the market because of high non-union rates and need of additional fixation, and also reported major complications, bowel penetration exactly, and it was left by most surgeons. What about MIS deformity correction? There are mainly anterior or posterior surgeries. In the past, we used to do some thoracoscopic releases, thoracoscopic instrumentations. However, because of requirement of addition of a posterior surgery, and the currently anterior releases have been replaced by posterior techniques, no more people are doing thoracoscopic instrumentations in deformities. Anterior release grafting and instrumentation using specially developed screws, rods, and reduction tools are possible, but mostly abandoned. There are some techniques used for the kids with staples, and they are popular using thoracoscopic approaches. In conclusion, if we come about the complication rates, postoperative infection rate after MIS is quite less than open surgeries. This study says that in 1,338 surgeries, 10-fold less infection than open surgeries. This is my first slide. Patient, there are significant advantages of MIS surgery. However, patient demands control our techniques. Probably patients want it more than the surgeons want. These are advantages and disadvantages, and outcomes are almost similar. However, more radiation for the surgeon. Thank you for listening to me.
Thank you, Professor Zirali. Great lecture. As always, we are very happy to have you in Sarajevo. Before the COVID pandemic started and confused our plans for the future. However, I hope in the close future we will continue our cooperation and your teaching.
Thank you.
Thank you. Adi.
Thank you, Professor Zilali. As Dr. Ibrahim mentioned, we are really satisfied that we have such an experienced neurosurgeon with us who shared his great lecture and great experience to especially younger surgeons who are interested in endoscopic and MIS surgery. First, do we have other questions from audience? You mentioned that there is increased radiation during the process of endoscopy and minimal invasive surgery compared to usual standard treatment. And also you mentioned that with endoscopic discectomy, there is increased rate of possible complication of CSF leak and damage of the nerve root. So how to avoid for the beginners, which would be tricks to avoid dural tear leakage and nerve root damage? And also, is there any study which confirms the long-term radiation which influences the health of a neurosurgeon who provides this technique? Thank you.
Yeah, I don't know about there is any study about the health of spine surgeon, the effect of health of spine surgeon. But I must tell personally, I have cataract surgery for my both eyes, and the eyes ophthalmologists say that it is probably because of too much X-ray. because it was in the younger ages. You can decrease the amount of radiation by application of navigation, probably, or fluoronavigation. But that may retard your surgical durations. Sometimes you may need more times to finish the surgery. The other one is the dural laceration. In the beginning, in the learning period, it is more common, dural lacerations. So then we can advise to make first discectomies, then switch to the lumbar spine stenosis surgery. In lumbar spine stenosis, as you know, it is more common to have a laceration, dural laceration, than disc surgery, disc herniation surgery.
So which instrument is the most cause, as you mentioned, probably the drill for the stenosis, or other instruments would increase the rate? So are those dural tears comes from the drill mostly, or from the Kerrison for the metrics, for example, for us who wants to begin with this new technique?
If I'm injuring myself, if I'm injuring the dura, it is mostly because during I'm using Kerrison rongeur, not the high-speed drill. If you use diamond bore tips, you don't injure the dura. But if you use normal rose drill bits, then you can injure that. Which may be a catastrophe, because together with the dural laceration, you can also chapter the nerve roots, which will be a catastrophe.
So how do you manage if you have a possibility of the dural tear? How do you manage it in a minimal invasive surgery?
In full endoscopic surgery, they don't make anything. They just place some fat graft or some sponge, and then leave it there. However, in tube-guided surgery, I stitch the dura most of the time. It's not easy to make a dural stitching in a tube, but there are special needle holders, and then with the help of your assistant, you can make it.
Mm-hmm. Okay, thank you for answers.
Since the muscles reapproximate after you remove your tube, because you are dilating the muscles, the incidence of CSF leakage after dural tear is quite less. But even with that, you can have a pseudomeningocele, small but a pseudomeningocele may develop. Because of that, I try to stitch it.
Okay, thank you for answers. Maybe Ibrahim has one more, as I see.
Professor Zileli already started his next lecture. Actually, we have one lecture more from him, gratis, let me say.
Complication avoidance in adult deformity surgery.
Probably he will show us even more experience there.
Yeah.
Maybe
okay.
If there is no another questions, huh?
I'm opening. I'm
Just like
sharing again.
For youngs, and now it's advanced course.
Yes.
Thank you.
I thank you. This is the second talk, complication avoidance in adult spinal deformity. First, we must start with that degeneration of spine can be considered as a natural process of aging. It mostly causes significant reduction in life quality. Actually, you can even say that the aging is being kyphotic. main symptom is pain, then deformity, then neurological deficits. And the surgery is not the sole or primary solution. There are many conservative measures like physical therapy, rehabilitation, manipulation, injections, and external support, and others. And if you are making a adult deformity, I mean, in the older ages, you are trying to correct a kyphosis or scoliosis, the complication rates is approximately 40%. Pseudoarthrosis rate may differentiate between 7 to 41. Reoperation rate is approximately 36%. It means that 1 out of 3 patients may need another surgery in the future. And the reasons of reoperation are pseudoarthrosis repair, need to lengthen the fusion, and adjacent level disease requiring decompressions. If you are making an osteotomy together with your deformity surgery, then the total major complications have been counted 42%. Risks are older ages, 2 osteotomies, and thoracic level osteotomy instead of lumbar. These are the complications of adult deformity correction. One is adjacent segment disease. It may be a caudal or cranial. Instrument failure and pseudoarthrosis, and systemic complications. Let's come to the caudal adjacent segment disease. L5-S1 problem is very often. If it doesn't happen, it may go down to sacral insufficiency fracture or even hip disease, because the body wants to be mobile, and then the body wants to preserve its balance. And the cranial adjacent segment disease is very common, proximal junctional kyphosis or PJK, and wrist stenosis or osteopathic fractures. How can we avoid adjacent segment disease? We can avoid it by applying shorter fixations, less rigid fixations, using hybrid systems. This is a new concept, not very new, but it may be new. Compressive forces instead of distraction, and provide sagittal balance and lordosis with osteotomy or interbody fusions, and augment upper level by a prophylactic vertebroplasty or a hook system or other devices. Caudal adjacent segment disease, L5-S1 is common. We state this. Because of that, we should try to stop at L5. Do not involve sacrum to fixation if possible, because L5-S1 non-union is quite common. If we really want to add S1, we must almost always use an interbody fusion at L5-S1. This is another issue, as I said before, sacral insufficiency fractures. This is if you have a very rigid lumbar fixation, then your sacrum may get fractured or your pelvis may get fractured. PJK is probably the most common complication of adult deformity surgery. The description is that if the angulation of proximal junction compared to preoperative measurements is more than 10 degrees, it is then PJK. PGF is another term. It is proximal junctional failure. If there is a mechanical failure and or spinal instability without any kyphosis. Incidence has been reported between 7 to 46%, and it's mostly in the first year. What are the mechanisms causing PJK? One is that lack of sagittal balance, deformity progression with aging. Somebody says that it is normal aging degeneration. Posterior ligamentous injury, facet injury or fracture, instrument failure, and degenerative disc disease. and these are the major and minor risk factors in older ages, wide preoperative sagittal parameters, using pedicle screws in all levels, overcorrection, and fusion of the lower lumbar spine and sacrum. These are risk factors. We must try to diminish them. And another study says that spinal implant density is another one. Is if you place too much implants there, you probably will have a PJK. And if your postoperative lumbar lordosis is not preserved or overcorrected, these are also two factors. And then another one is PJK is more common with greater postoperative lordosis of the upper lumbar spine, greater postoperative upper instrumented vertebra angle. This is one example on the right. The overcorrection has caused a PJK afterwards. This is a small series, 44 cases, PJK 38%. Risk factors, another risk factor has been announced here, lower muscularity and higher fatty degeneration of the back muscles, especially at the thoracolumbar junction. How can we prevent PJK? Provide a good sagittal balance, multi-level stabilization, protect soft tissues on upper instrumented vertebra, use hooks, wires, or polyethylene junctional tethers at the upper instrumented vertebra because they are free from softened bone. I mean, if there is osteoporosis, you can rely more on the hooks and wires instead of pedicle screws. Proximal transition rods of reduced diameter, less rigid instruments and hybrid constructs, cement augmentation in the upper instrumented vertebra and upper levels, use composite metal in long fixation, cobalt chrome rods probably, and the distal osteotomy. Achieving a good sagittal balance is one of the most important factors in that. PJK expected if sagittal balance is not achieved, spine is very rigid, and compensation mechanisms are not working well, and the muscles are so weak. In case of osteoporosis, what can we do to prevent PJK? Use screws with larger diameters and longer screws. Use more fixation points, and we must not use forceful correction maneuvers, especially in adult osteoporotic patients. Use cement to augment the bone around the screw. This is one of my cases. I have done an osteotomy and finished at the upper T10 level, but then I have to augment with cement T8, 9, and 10 with prophylactic vertebroplasty. I do it separately. Actually, I finish the surgery, and after that, I use extrapedicular approach to bodies, and then inject cement through that vertebroplasty. This is 3 levels: one in the upper instrumented vertebra, 2 others in the 2 upper levels. No correction loss in 3 years follow-up. So there are papers telling that the prophylactic vertebroplasty is good. This case series is with cement, PJK none; without cement, PJK 15%. This series again, PJK is good, but this series say that the methyl methacrylate decreases disc nourishment and causes degenerative disc disease and causes fracture risk on adjacent vertebra. So then this series say that prophylactic vertebroplasty is not good. But about spinal hooks, instead of screws, the hook with hook PJK incidence has been found none here. And then here is less than pedicle screws, another series. And then to optimize your decision making, Dr. Hart has developed a PJK severity scale in 1,200 patients. So then severity score depends on the neurological deficit, focal pain, instrumentation problem, and other factors. So if you count more than 7, then the revision because of PJK will be necessary. And more revision if traumatic etiology, if proximal junctional angle is high, sagittal vertical axis is high, female population, and combined approaches. How can we treat the PJK? Mention the instrument. If we have finished at L2, we must go up to T10. If we have finished T10, we can go up to T2 or T5. We can add vertebroplasty, use hook, make decompression, and correct sagittal balance. These are some examples. This is on the left, you see typical PJK, and on the right, posterior osteotomy and T11 to L5 fixation. There's another case. Actually, I borrowed this slide from my friend Sedat. It was the first revision. A PJK has happened here, and then second revision, another PJK happened. Third revision, every time surgeon is going up with extension of the instrumentation, another PJK, and then at the end he has gone to T3. Comments for PJK. PJK and PJF are most common complications of deformity surgery. In adolescent scoliosis, it's not that much, 7%. However, in adult scoliosis, in geriatric patients especially, it's quite common. And I have mentioned the measures how to prevent PJK by your designing of the construct. And in general saying, revision incidence in adult deformity surgery is about 35%. I have told this. One is the proximal junctional kyphosis. The other one is non-union and infection rates. And major blood loss may not be tolerated by the elderly. Systemic complications must also be in our minds. And then we must try sometimes, in case of major systemic disease, simple decompression and limited fusion surgeries. And the recent trend is MIS surgeries to reduce the blood loss and reduce the systemic complications. These are major complications with MIS surgery 14%, open surgery 45%, a large multi-center study. Again, MIS techniques is better with this 2014 series. And we must also predict worse outcomes before surgery by using frailty index, exhaustion index. So then the geriatricians have defined robust, prefrail, and frail patients. We can define it by using simple scales. And we must know that the complication rate in frail patients are quite higher than non-frail patients. Even 30-day mortality rate has reached up to 16% in that 189 adult trauma patients. This is frailty defining criteria. I don't want to give more details about it, but weight loss, exhaustion, low energy expenditure, slowness, weakness, and overall frailty score must be defined. And then we must try to improve outcomes of spine surgery in geriatric patients. We have reviewed the literature on that. And in conclusion of my talk, we must try to perform fixation as short as possible. If you decide to perform long fixation, we must be aware of sagittal balance and cement augmentation for osteoporotic patients, increase the height of the disc by interbody fusion, and perform osteotomy if necessary, and think twice for L5S1 level. If it is very necessary, make always an interbody fusion at that level, and sometimes use additional screws, S2 and or iliac screws. And tell the patient for very high complication rate and reoperation rate. And then you must be aware of the postoperative complication like delirium, depression, and psychosis. And then we must not just talk about the radiological views of the patient, but the patient may mobilization and frailty index must be always mentioned. Thank you for listening to me.
Thank you once more, Professor Zilali, for a great lecture. Since I don't have experience in adult deformity cases, I will kindly ask other attendings to ask question if you do have about the lecture. Professor Ibrahim is there.
Yes, I'm here. Great cases and great surgeries, and of course those advices you gave us. However, yes, this is, you show us some of cases that mostly young neurosurgeons even not assisted in our region. But for example, if we have some beginner who are trying to put, for example, simple lumbar fixation, 6 screws or something, could you recommend some easiest, let me say, the easiest cases for the start to put the screws to avoid those complications you show us? Which are the cases the best for the beginners, for the PLIF or T-leaf, or with stenosis, without the stenosis, unstable or stable, with the compression or just fixation, how to start?
Yeah, in the past I used to say for beginners it's better to start the instrumentation with trauma and tumor cases and not degenerative cases.
Yeah, that's
if you want to do a degenerative listhesis or isthmic spondylolisthesis, you want to do a fixation, then try to be as short as possible. As short as possible. I see sometimes some colleagues, let's say there is L4, L5 degenerative listhesis only, they add one more level in the upper level, L3, 4, 5. This is not necessary actually. If there is no instability at L3, why do we add L3? It's not necessary. But if you want to correct some deformity, like a significant kyphosis or significant scoliosis, then you must obey all the instructions I have given here, like do not stop at the junctional areas, do not stop at the apex of the deformity, use interbody fusions, be aware for osteoporosis, and add cement augmentation sometimes. Those are measures we must always obey if you are doing a deformity surgery. There is one word, the sentence that saying all spine surgeons are deformity surgeons. Either correct them or create them.
That's probably true.
Yes.
Okay, thank you. Any question? Other guys? Audience?
Professor, if you have a patient with osteoporosis, how do you treat him first? Is there any special treatment which you propose, or you still go with this which you showed us?
Yeah, actually, you can try first to give a good osteoporotic treatment, especially synthetic calcitonin preparates. And there are very nice drugs now. And you must evaluate the DEXA scale and D vitamin levels. And then after some period of treatment, you can try to correct the deformity. There are also, as I mentioned, there are also some hybrid systems. Sometimes you must not be very rigid, but the results are not well given yet. We don't know yet the results. Probably after a while, we will be using more hybrid systems.
Mm-hmm. Okay, thank you. Any other questions? Then we can move forward. I would invite Professor Salman, if Professor Salman is with us.
Thanks a lot.
You're welcome. You're welcome, Professor. Thank you so much.
Professor Zileli, we're happy to have you here. Enjoy Mumbai. Adi, here is, as I have information from the Karachi, from Pakistan, Professor Sharif have to go to the OR for the emergency, and here is his assistant, Dr. Imadullah. Imadullah, can you hear us? Dr. Imadullah? So probably they will enjoy us soon. However, we have 2 lectures more, and maybe we should discuss if there is some other questions from our young guys, or we can make even the short break if somebody wanna drink a coffee or something. Is there any question for any of professors or any suggestion for the future or for webinars? We are at your disposal.
Professor Kato also wrote that she's another webinar, and she proposed 4th, which you mentioned, Dr. Ibrahim, 4th ACNS Bosnia webinar, and we were discussing about the topic. So the next topic would be glioblastoma treatment. We have also Dr. Almir, who is a PhD candidate in glioblastoma. So I would kindly ask all the participants who wants to join us and to maybe propose a topic of a treatment of glioblastoma for the next our webinar in February. And this is, I believe, we started, but it's great that we are in continuous process and we have more participants. So I believe it's going to be interesting in the future. If there are no questions, Ibrahim, maybe we can have a short 15-20 minutes break, coffee break, and as soon as Dr. Imad responds, we will continue our webinar.
Yeah, now is something like less than 6 a.m. in the United States. Also, I will just invite Professor Arnautovic also to enjoy us as soon as possible, even earlier than scheduled is on his for his presentation already done. So let us have a breaks for a few minutes and then we'll come back again.
Okay, thank you. Okay, we are here again. Do we have Professor Salman lecture? So far, I don't see Professor Salman as well as Iman. So then maybe, Ibrahim, we should wait for Professor Arnautovic to join us when he confirms to you that he is ready. Now in the United States is early morning.
I tried to contact him by phone, but he doesn't answer still. Not. So I know. I don't know what to do. Maybe. What about your another symposium with ACNS? Maybe you should start with.
We cannot, because it's not related to Bosnia. It starts later, because we have to wait for Professor Kato and Professor Shubin, as well as the other speaker, Professor Yang from China. So the next webinar will start at, I believe it was 2:30.
Maybe I see here is Professor Kato still here? I know that he has another obligations, but if here, maybe I would like to say a few words to her. Professor Kato?
I believe Professor Kato is currently in other meeting. Yes.
However, let me say a few words to young neurosurgeons in Bosnia Herzegovina. Thank you to Professor Kato and his foundation. We get some support for young neurosurgeons in Bosnia Herzegovina for the education. So those grant is already accepted by our society. And as you know, there is the process of application for the support of young neurosurgeons. I hope that those of you who get the part of this grant and enjoy some educational activities worldwide will send also email with thanks to Professor Kato for her continuous support to our neurosurgical community and society in Bosnia and Herzegovina and the region. And also I hope that in the future will some guys from Bosnia and region, also as you, Adi, did already, could be in have a chance actually to visit maybe Fujita Health University and Professor Kato's department. And also you are, what we say, the very nice example how the time you spent in Japan can at some way make a direction of your future in neurosurgery. So you are now the member of alumni of Fujita University, and that's also that's also our connection with the ACNS and Fujita University, which is now even better than in the past. So maybe Adi, concerning that, you can say a few words about your experience in Japan and what's a difference in the education meaning and also experience with publishing, but also if you want to say a few words about the surgery. But maybe those your way how to go there, what is the difference between education. We know all that Japanese people are the maybe best examples in the world, how with such patient they are learning and so. Adi.
Okay, thank you, Ibrahim, for your question. First of all, I will have a next topic in next following webinar, my vascular cases. So maybe for the attendings, we'll see some of cases which I've done with, of course, you as a consultant and Dr. Eldin as a consultant. Following the education, Dragan is here. Dragan is a hard-working, great resident who first was in Marburg, and then he stayed in. Then now he's in University Hospital Mainz, and he's publishing a lot. And I shared when Professor Kato asked me about the next fellow, I shared Dragan's name because of his. He wants to do it. There is a very wise wisdom which I shared with my students, which says, when the student is ready, teacher will appear. So everything is about the student, everything is about the resident. If a resident wants, he will find a way to find education, or young neurosurgeon. It's everything up to you. My first connection with Professor Kato was here in Sarajevo, for our Southeast Neurosurgical Society meeting, and then we stayed in contact. How did my way go? I visited Professor Arnautovic in Memphis, Tennessee, and then after I visited Professor Osama Al-Mefti in a cadaver St. Louis skull-based course. And then, you know, when you make one or other step, the other steps become more steep. Professor Arnautovic recommended me to Professor Bashkaya, and I visited Professor Bashkaya, who told me, when I asked him, Professor Bashkaya, how you are such a great neurosurgeon, I like your skill, and how did you become? He says, if you want to be a good neurosurgeon, at least you have to visit Japan. So that's one of the biggest cerebrovascular surgeons who works in the United States told that you have to go to Japan. And then he asked me, of course, during our discussion, would you love to visit Professor Kato? And that's how he was writing to him. I don't know, maybe it's maybe those are lucky circumstances, but I believe as a young neurosurgeon, 3 years experience now, young neurosurgeon, that it's everything is about you. So if you want to make a step forward, you have to do it first alone, to show the personal enthusiasm, to meet the people, to ask any professor, if you ask in a world, I believe so, you can, Professor, may I visit you? As I met Professor Steno, I asked him, may I come to see how do you do your craniopharyngioma? He says, you're welcome anytime. So if you ask anyone, anyone is opened for you, but you have to be one who will approach. Neurosurgery is like male to female relation. Female is looking at the man, but she doesn't approach. Of course, the man is one who has to make a first step. So you as a young neurosurgeon, as me are, and the residents, it's up to you. You are a male, and education is a female for you. So first steps is it's just up to you. So at the end, Dragan was the guy who really joined first Fujita Alumni Association with the lecture, and he was committed, and he really wanted to visit Professor Kato. And as I told him, that will be probably the best thing that will happen to you, and it will totally change your way of thinking as a neurosurgeon, your way of microsurgical skills will be for surely improved by after Japan. Japan really changed me a lot in a way of neurosurgical thinking, exposure, very important neuroanatomy knowledge, which I gained there. Winter seminar, cerebrovascular seminar, which is fantastic. Dr. Leo is here also with us, so he was in that period. We worked together there. We organized that winter seminar together, of course, with the leadership of Professor Liu, great guy from Malaysia who is my friend. And after winter seminar, experience in models, clipping in the models, bypass surgery training, endarterectomies, and when you see such a high number of aneurysms and all other vascular cases, as well as skull-based cases, tumors, I believe that you get so much self-confident that you can approach to these advanced cerebrovascular lesions. So you, Ibrahim, you are a consultant, a neurosurgeon, and you have a great experience in vascular, and you know how big training you had to have before you approached. It's not just that I will be cerebrovascular surgeon or I will be skull-based surgeon. There are steps which you have to follow, which will include, of course, your training, but which have to include fellowship, observership, even research where you can observe surgeries and do animal training and do cadaver training. You have to, of course, read a lot and learn a lot, and then you have to visit a master, a great master, like Professor Kato is, and Professor Sano, Professor Katsumi Takizawa. I will never forget those STA, MCA bypasses, AVM surgeries, every day 3 to 4 aneurysms in different locations, trigeminal neuralgia, PCU, cavernoma, endoscopic different approaches. And then after, you can start as a beginner. So those are the conditions which you have to feel before you start. And if you want to go other pathway, I believe that there are a lot of pathways for any subspecialty of the neurosurgery. But by my opinion and my steps, which I followed, as you did, Dr. Ibrahim, also, I believe that the only right way is to go through these steps. There is no approach to the aneurysm. There is no approach to the patient with the aneurysm, or rather, if you didn't have good neuroanatomical cadaveric course, if you didn't see hundreds and hundreds and hundreds of those surgeries, if you didn't assist hundreds and hundreds of these surgeries, and if you are not, of course, member of the update data, as we have these webinars. So these webinars are updated from such outstanding lectures as we did have today. You have to be part of that. Otherwise, I believe that it's not the right way to the final goal. Sorry, it was a wide answer, but when you asked me, I was.
That's okay. That's okay. Thank you, Adi. That was actually a question and the discussion during this period. We are waiting for the next speaker to invite them to talk. It's good to talk about the problem and the ways how to improve your knowledge and be up to date with the evidence-based medicine. Also, of course, there is no first-class evidence in neurosurgery so much. However, you always can see the meta-analysis. You see that well-experienced speaker here always mention a few the biggest series and meta-analysis, and they say their own experience also. So I think so that this kind of webinars is something it's actually a gift, let me say, gift from the COVID, that we introduce this kind of education so often, and you have practically the best speakers online. You can sitting this Saturday at your home. It's raining outside in Bosnia and Sarajevo, but you still can learn very easy. No spend the money, no, without asking your chair, your boss to let you go around the world to learn, as I did 20 years ago. You don't have to passing airport trying to find the cheap tickets at hotels and so and so. So actually, of course, the most important part of education should be the education outside in different environment than you is even in the United States and some European countries which has the very good educational process and training in their own department, famous departments. They sent after the young guys pass the residency program, they send them somewhere outside for 1 or 2 years for fellowship, very often to United States or to Japan. For example, our friend, you're one of your mentors, Alberto from Verona, he visited Japan, or many of my friends from Germany visited UK, visited United States, people from the United States coming to Zurich or Zurich, Hanover, and so even in Sarajevo, some guys from Napoli, UK, and sometime another city, Turkey, Czech Republic, I know where from we had people in the past. So it's very important. So there is 2 things actually. First one is that you can learn now by the live word from those webinars. You can ask whatever you want the teachers and the speakers. You can even contact them after the webinars or directly during the webinars to visit them, and which wasn't possible in my time of education 15, 20 years ago. And I know I send the emails and then wait for answers for months or weeks, and then go there, find a train on flight and so and so. But now those teachers are here. And another things, it's that when you connect with them, you can ask for the fellowship or short fellowship, few weeks, 2 months. You have to go there, and they will be updated. They will see different, not always the better way how to solve the neurosurgical problem, but different, which is also very good. You will compare your own knowledge or techniques and standards in your department with those you are learning in the outside your country, which is also important. But basically, you mentioned, Adi, you mentioned actually the be how to updated, read, learn basics and news in neurosurgery. I mean, it's mandatory for all young guys, not only young, but also experienced. And I'm reading every day, at least, let me say, half all new things from neurosurgery. I take a journals or online or something, trying to catch new things and be up to date. So what's the problem there? For example, those guys here who passed the EANS courses or are still there in the training, as you are, and Fahrudin from Zanissa, and Dragan is also. Do you are Dragan or EANS courses already? Are you EANS courses? Yes.
Yeah.
And
for cycle, yeah, hands-on. Yeah.
For cycle, also Mirza.
Cycle and hands-on also. Yeah.
Yeah, great. Mirza passed also those European exams. One of the questions, actually, as a trainer there, as a professor at those training courses, I'm the person who also developed the questionnaire pool for the exam. So we are trying to put the question in the poll for the European exam, which are up to date. So to put the question there, I have to read the most recent publications, meta-analysis, and so and so. And that, of course, connected in my experience. And all the professors in European Council doing the same. They read and make a question which are up to date. Of course, there is some basic, you don't have to up-to-date anatomy, but this. And the question is also for your exam on the European course, it will be sometime or always you have some kind of questions. The recent standards in some field of neurosurgery. So you cannot pass the European exam without reading the newest information in neurosurgery. So this kind of education, it's not only the listening the lecture of expert, it's not just communication with the mentors. You can ask for the fellowship in their department. It's not connection between all of us. It's the collecting of the new things, newest information, neurosurgery, compare yourself with the knowledge of your colleagues, younger and older, that you are comparing the surgeries in Pakistan, Argentina, United States, Japan, China, Bosnia, Croatia, Germany, and so on. So I think that those of young guys, especially in Bosnia and region, who are missed this kind of education, which is completely free, which is in the free time, in the Saturday mostly, I think that they missed the chance.
You know, when I was a resident, you were, I just started, you were already a neurosurgeon. But as a student, if you remember, I was coming to you, and I remember when you were getting abroad for education. So there was a visa regime first.
Yeah.
Then you had to take old copies of the articles, books, etc. Now everything is available at your home. You couldn't imagine one day that Professor Kato, Professor Zileli, Professor Bosniak, Professor Arnautovic will sit with you in your living room. So they are there. You just have to take it, just connect, and it's so easy to take knowledge. In a previous time, it wasn't so easy. But maybe I should ask Dragan, because he's a hard-working resident, and whenever I call him, Ibrahim, he's in hospital. So it's at 10 o'clock in the night, it's 11 o'clock, it's Sunday, Saturday. Whenever we are in touch, he works. Dragan, for the other younger neurosurgeon here who are attendings, please, or another, of course, from Asia and all countries through the worldwide, can you share us your story of residency in Germany? And what are your obligations? What do you do? How many research do you do? How many studies do you do? How it influences your private life? And how it's possible that I see you in each webinar always, and not just this webinar, you are always there. How did you manage all of it?
Do you think it's worth
I'm here. It's a connection thing, I think.
Can you repeat, Ibrahim, because he didn't hear you? There was a connection problem.
Do you think it's worthy to
I start my residence in Croatia, and I think that's when you have a dream, you just have to catch him. I started my residence in Croatia. In Croatia, I was 6 months, and then I moved to Germany in Marburg, where is Dr. Pojskic, actually. And then after Marburg, I moved to Mainz, where I'm right now really happy. I have OP cases in Germany is so that you have to operate not as assistants. You have to be operator. So I'm already at the third year of residency, between 4 and 5. And I have my program here in Mainz. It's very good. I do a very much research, and on Germany, when you work on university hospital, you have to do that. You have obligation, and my chief, when you have a yearly meeting with chief, the first question is what do you do from research, and how paper have you published the last year. And when I've been a week ago by chief, and I said him that in the last 9 months, I published 5 papers, 3 original research, 1 case report, and 1 review, and 3 are in submission process, all dry.
Dragan, sorry for interrupting. Can you please repeat now your publications? Please repeat it. We just want to hear once more. For last year, how did many
in the last 9 years, 5 published?
Just 1 year, and
so
please.
It's September, so but I think Eddie said I'm always in hospital, and my wife is better to ask answer the question. So yeah, actually we have I'm a first author in the three original research, and we published one case report about multiple myeloma. We published one with Professor Arnautovic, one very big supra spinal hemangioblastoma review. We submitted the last week the Supra, and we published one case report and 3 original research. And when you are so my day begin at 6 and ends at 21, and that's all day. And I think that when I work, so you have to have at the end results, and that is statistically. And here in Germany, I learned discipline. While here when you want to make research, you don't need statistical. You will not learn alone. So in Croatia, when I wanted something, then the chiefs say, yeah, okay, we write some people from a statistical department on the paper. Here in in Germany, if I want to make meta-analysis, if I want to research biological markers in spinal meningioma, you just have to write chief. You have to do your expose, and you can do that. And that's something and you are a first author. That's very important. In our department, our chief or our senior consultant are always at the end. And in our countries, we have to say that is always chief the first one, and then all other who works at the paper are on the 3rd or the 5th place. And I think it's not correct. And I learned that here, and it functioned. And I don't know. I think that's I spoke much with Bekir and with Adi, and we in Germany, we have obligation to have a participation in course. We have obligation to publish 2 papers, and 1 have to be original research. And that's very important for us, for our clinic. While then we can say, yes, we have published 20 papers, we made research, and we get a money with research. And that's important. While that's very important. Why is that so in Germany, and I know in UK and in USA, so it's always the research first in resident level. At the end, I think there's a difference between operation things is that here in Germany as resident, I have my patient, and I have, for example, 100. I have to operate 100 spine cases or 50 tumors, and on all that operation check or Bericht, I have to be operator, and I made operation for incision to closure, and I think that's also something different between countries and programs. I don't know, you Adi and Abraham, you have to say something something else, but I want to show what I see here, that here in many of Becker is here also, and Emma I think is also here. Can you share my screen? But I want to share with all resident from Switzerland, from Swiss, in Bern and in Geneva and in Basel. We have all 3 months hands-on course. And I want to invite you as resident to come, while it's not just for German and Switzerland residents, but also for worldwide. In Geneva, the last month we had a resident from Spain, from Frankreich, and I think that it's good that someone from you come to I think that's in October or November. We have craniotomy course. That's cadaver course. I think that cost you have to pay 500 euros, but that is not ACNS. I think is 1,500 euros. So I think from resident level is that some better. But can you share my my screen, Adi or Ibrahim?
Just a second before you share your screen. Let me ask you once more, just to be repeated for our resident and young attendees. So you have to do research, and as you mentioned, and does it influence the energy which you spare in the research? Does it influence your OR work? Are there conditions? I agree with you that any university hospital has to be academic, except the professional work. So by your opinion, how would you change things better in less developed country than Germany, Japan, USA, UK? How would you, what would you recommend? How should one neurosurgical resident behave? Would you propose that there are some conditions if you want to go to OR, for example, and if you want to get a chance to operate or assist, that you should first fit some of the basic research conditions prior to that, so you can show your consultant and your senior that you are a hardworking type, that you are not just there to, I can say, take knowledge as a thief, but just to be a real resident. How would you change strategy, for example, in Balkan Peninsula countries? What should we do to improve our discipline for our younger, I'm young too, of course, but I'm asking even for myself, but also for the generation which comes after. What you would propose to change here? You were here, now you are there. What's the step?
So I think that chief or senior consultant have to do more research. Why I learn all my skills that I have right now from my deputy of chef, Leitende Oberärztin, or a senior consultant. So she made intracerebral hemorrhage experimental study, and when you learn a lot, you prepare you for operation room OR also. When I have when it's different, because we made a lot of anatomical study, and when you have to learn 10 papers about retrosigmoid approach, then you see and you prepare you for OR. Let's say as resident. I think on Ibrahim level, that's something total different. That's his daily routine, but on the resident level, I think that is very, very important to read. And I have contact a few months ago with Juha Henesniemi, and then he said me that had mostly learned as young neurosurgeon, as residents, by writing, and that's really when you have to make a meta-analysis, review some research, you have to prepare you for thinking about the thing, for thinking about sarcopenia in spinal cord tumors. You have to thinking about CMV, cytomegalovirus in glioblastoma. So you have to read a lot to come to a level that you can writing something about it. I think so.
Dragan, trust me that I'm reading not for every surgery, but all the like they say, very complex surgeries when I have day before or night before, I am trying to be updated, look at some pictures, anatomy. I'm going through the surgery 3 times during the night. In the morning when I'm going to the department, I am thinking how from skin to skin, how I will approach which problems I met there. And then I'm even sometime on the morning meeting, I'm looking on the mobile and read a little bit some tricks and tips and problems which I can experience during the surgery. So reading is obligatory for all the people. Even you see those webinars you organize for you. I learned maybe as you, even sometime maybe even more than you. Not only by the speakers, because I always see the different approach, even if I operate by myself something and I'm experiencing that area, of course, but I learned the tricks from Pakistan, from Turkey, from United States, from Brazil, from Germany, you know, always something new. And also I learned from the young guys, not always the advices, but if you ask me something, you push me to learn. If I don't know the real answer, after the webinar, I will try to find the answer. So that's push us to learn. If I'm asleep now or looking to TV, of course, I'm be on same level like as yesterday. Not on the same level, but lower level, because I forget something from yesterday. If I'm not read and if I've not learned something today, I am worse surgeon than yesterday.
Do you all agree when we discuss this topic? First, I want to say that we have in questions and answers Melika Kovčić, who says that she's so grateful for amazing advices, and we are lucky to have you, Melika, here today with us. Do you, after this discussion, believe that each resident, depending on his, do you like him or not, should get the same chance? Is it same, Dragan, if you are fighting research, publishing papers, pushing your career in front, but also you're consultant with the papers and your clinic? So if you do all of that, is it same that you should get each chance in OR or even less or even more? What's your opinion about that? And also I will ask later on Mrs. Yehan and Dr. Liu, if they are here just to join us from different perspective from Malaysia.
I know you. Thank you very much for your question. I know a few chief or department in Germany where you go to opera room, how much you publish. Yeah. In our department, it's not so. We have our plan, our hierarchy that the senior residents operate skull base or the assist Pascal base, and the other one on the smaller easy OP. So I know that's in Germany. I know that's when you publish, you can go in opera room, but at the end in Germany we all have to have a number of surgeries. So I don't know in Croatian or in Bosnian. I think in Croatian not, but in I know a few houses here in Germany where one of my friends are 7 or 8 year residents when you because they don't have a number of operations, and that is something total different. I think that's in Bosnian, Croatian, Serbian, we go to the proof to the exam after after 6 years and you are done your residency here. So my chief will me approve my residency when I have a number of, when I'm not happy here and I want more to operate, then I have to go somewhere else. So.
Yeah.
And something else that in Germany, all university house have intensive care unit, and that means that we have to, we all are 1 year of the intensive care unit. What is no different that we make alone duty, or we are alone. I don't know how to say that on English. I think on duty we have just consultant on call, on our consultant, our operators, or senior surgeon, neurosurgeon is always in at home, and we are alone in operate on duty. That's different, and the different that we have that just a university university house hospital has also this intensive care unit, where you have to intubate alone, thorax drainage on alone, all what make anesthetist you make as neurosurgeon as at university, all university hospital in Germany. And that is something different, I think, to worldwide, while I think that just in Germany is that so. So you have to do all your skills, and you learn a lot of skills, and that's something totally different. While I'm from Croatia, and in Croatia you have to do just things for anesthetist, and then you come here and you have to intubate, you have to implant pleura cut, you have to bronchoscopy, and that all you have to learn. And I think that's a too big difference between two programs. And at the end, our residents go home 18, 19. When we are with second meeting, we have second meeting at 15:30. We all go to make research, and that is a big difference between programs, I think.
Yeah. Okay, thank you. I will kindly ask Dr. Jehan Ziua. Please, can you join us? I see you as a panelist. I saw you a couple of minutes ago. Oh, thank you. Hello once more. And can you please introduce yourself to the audience? And can you, if you were listening our discussion about what should young resident and young neurosurgeon do to get a chance to improve himself? So please introduce yourself and tell us your opinion. Where are you coming from, and what's the practice in your country?
I'm from Shanghai, China. I was graduated at the Jiao Tong University Medical School, which is a top one, almost top one or top two in China, a medical school. My major, my MD and a PhD, I was trained as a general surgery after I finished my PhD and MD. Then I transferred to neurosurgery. I was trained in pediatric neurosurgery and adult neurosurgery. And I also completed my postdoctor in brain surgery, brain tumor immunotherapy. My career life law is different and special. And your question is,
it's just related. Thank you for introduction of yourself. It's related. What are the obligations? What were your obligations, except of course assisting surgeries and department and ICU work? what were your obligations regarding research during your process of residency, and how did it influence your future career?
I've almost finished my training in neurosurgery department, and I want to pursue my research in brain tumor direction, combine the immunotherapy. So my future plan is pursuing research. I think neurosurgery, the surgery is the first step and very important. But in brain tumor topic, I found surgery cannot resolve all of the problem, because in malignant brain tumor cases, surgery and chemosurgery, radiosurgery only can prolong patient's life for 1 year or 2 years, but almost grade 4 malignant brain tumor will repress, come again. So I'm trying to pursue the new brand new therapy method, such as target method and or immunotherapy method. In China, we have several clinical trials for the CAR-T therapy, chicken point therapy, and just to try performing clinical work. So actually, I want to add another my education experience. I got education for clinical research and clinical trial training as a program in Harvard Medical School in 2020, before the pandemic. I'm very lucky I can finish my program training. Yeah, so actually now I want to immigrate to United States and pursue my research. I want to apply a research position. Yeah.
Okay, thank you for sharing your experience.
Yeah.
Do we have also Dr. Liu here? Dr. Liu, if you hear me, I would love kindly ask you to join us in discussion, just to see your. Okay, I cannot see Dr. Liu in here in a panelist. Then maybe your Dr. Ibrahim, if we don't have, we are missing our time for the lecture which was planned.
Yeah, Adi, I think so that we should stop here. The people has another obligation. If there is another questions, Leo is now here. If you want to ask him, he's enjoying us just now again. So if you want to ask him the question you already tried, and then we can stop with today's webinar, finish it, and postpone one presentation for our next fourth webinar on February 2023.
Okay, Dr. Liu, if you hear us, you can join us whenever you are ready. Just as Professor Kato and in our communication, as I have mentioned, the proposal of next fourth Bosnia ACNS webinar is a glioblastoma. So I would kindly ask you, even Dr. Yahan, if you are researchers in a tumor, to join us, and please, you can contact Dr. Ibrahim for application of your topic for one of next webinars. We would be really glad to have you in February, that you can share your experience. You can have it research, you can show your video of your cases, whatever you decide. It fits this topic with the glioblastoma. And I will kindly ask Dr. Almir, our great young colleague from our department, also because he works in a PhD thesis in glioblastoma, he can share his current results, but also he can share some of his experience, videos, etc. So also there are Professor Harun from Tuzla city, Bosnia, Professor Selimovic, there is Dr. Fahro. All of you are welcome to apply with your topic. I believe that more we share our experiences, it will influence our collaboration, but we can always see something from each other. Sometimes maybe we should also apply with a complication in neurosurgery webinar, so we can learn from our complication for morbidity, mortality, any kind, as I showed my Chiari treatment today. Perfect surgery. We were very satisfied with neurological outcome, but we had that fistula. So I believe that from complication, we can learn mostly one from each other and how was the strategy to solve it. Anyway, if Dr. Liu is not here, maybe Dr. Ibrahim, you should conclude the session and we can move next.
Yes, Adi. Thank you. So in the previous communication between Professor Kato and me, we proposed also a minimally invasive treatment topic for the February, and also gliomas. Now we updated it. So there will be two main actually topics for the February. Also, we already have confirmation of some very famous guys in those fields. For example, Professor Booth from St. Jude in Memphis, one of the best or probably best pediatric neurosurgical department in the world, and a few guys from Western Europe, and probably we'll get some presenters from Japan and Asia. However, I really believe that will be even better a meeting than this today. So I would like to thank you to all of you for participation today, especially Professor Kato, Dr. Liu, and our National Society Coordinator for Cooperation with CNS, ACNS, Dr. Adi Ahmespahic. So please enjoy with us, discuss, ask the questions, and see you, all of you, I hope, in February again. February 18th, put in your schedule. Good luck, have a nice weekend.
Thank you, Dr. Ibrahim. Thank you to all participants, and hope to see you soon. Bye.
Thank you. Thank
Bye.
you.
Thank you.
I have no prepared to talk. I just want to hear and learning from your masters. I also have some interest in rare tumor in pediatric neurosurgery. Sometimes I had some consulting with Chinese patients and help them to get a new strategy for treatment. If you have a tumor sample and a tumor bank, maybe we can organize to do some research, such like genomic profiling and new therapy and funding. Okay.
Okay.
Thank you. Thank you. International Research
Thank
Center.
you. And goodbye. See you soon, all of you. Goodbye.
Bye.